Someone to give us the words.
Okay, good morning, everyone. I am Dean Wong. I'm a consultant urologist here in Jamaica, and I will be the moderator for session 1 of our symposium, Prostate Cancer Awareness Symposium, brought to us today by Jamaica Cancer Society, Guardian Life Foundation, and the Jamaica Urological Society. We thank them for making a special effort via our virtual Zoom platform. It will also be live streamed on the Jamaica Observer website. So, just as a preamble, did you know that prostate cancer is the most common cancer in Jamaica and also the leading cause of cancer-related deaths? Stay tuned as we hear more from our expert panelists later on. I'll use this first opportunity to explain to the audience that about the format. Each of our expert panelists will be given 20 minutes to present an excellent talk. Please try to stay within that time frame. And for the question and answer session, these will be done at the end of session 1. And we're asking that you type the question into the Q&A section at the bottom of your screen, and then I will read them out. We may not get to all of the questions, but we'll try our best, time permitting. And we strongly advise that you use your professional name just so that we could identify correctly, and also for CME purposes. And then if you could also indicate which one of the speakers you want the question specifically addressed to. So without further ado, let us begin. We are joined by Mr. Earl Jarrett, a man of many hats, but he's here in his capacity today as chairman of the Jamaica Cancer Society. Mr. Jarrett, good morning. Over to you.
Good morning to you, Chair, Dr. Dean Wong. I'd just like to recognize the other panelists, Dr. Warren Chin, Dr. Robert Wan, Dr. Gareth Reed, and Dr. Roy McGregor. And I'd also like to recognize Mr. Michael Leslie and Julian Brown from the Cancer Society and the team from the Jamaica Cancer Society for hosting this important symposium this morning on prostate cancer. As you all know, the Cancer Society celebrates 65 years of providing service to Jamaica this year. The Cancer Society is a voluntary charity with a mission to reduce the burden of cancer on Jamaicans. That burden has been lifted by the provision of information, testing and diagnostics, and providing treatment options and psychological support for men who would have, and their families who would have had the prostate cancer. The Cancer Society costs approximately $100 million a year to operate. And the work of the society, as I said, includes providing information, screening, and financial support to patients when it's available. During the past year, the Ministry of Health, and with the support from the Minister, launched a program called the Bossman Campaign, where the ministry sought to increase the levels of prostate cancer awareness across Jamaica, and in conjunction with the University of Miami, also staged a program to increase screening in certain rural parishes, particularly St. Thomas. By way of background, in terms of what happened over the past year, we also had a group of men coming together in a group called Brothers United Against Prostate Cancer, chaired by Michael Giordini and being established under the auspices of the United Church in Jamaica to provide support for men who have had diagnosis for prostate cancer. That group will operate as the women do in the breast cancer support movement called Reach to Recovery, where they will be in constant touch with the patients and help them to navigate the challenges of prostate cancer. Sorry here, just 1 second, just making sure I'm plugged in. Okay. Um, yeah, I'm back now. Thank you. That group seeks to provide support to men who have been diagnosed with prostate cancer, and they were just about getting started when we had the COVID pandemic in Jamaica. The COVID-19 pandemic has impacted the society quite negatively. At the start of the pandemic, we literally had resources only to last another 2 to 3 months. And thanks to the staff who decided to make salary sacrifices, and the help from donors such as Guardian, Sagicor, CIBC, the producers group, and the Jamaica National Group, were able to continue to keep our staff engaged and began to offer the services that we normally do when the government gave the clearance for us to so do. The society naturally had to comply with the protocols and guidelines set down by the Ministry of Health. And we actually closed our screening facilities and persons worked from home during that period. It meant that our fundraising activities that literally came to a halt. And to this day, we continue to seek ways of funding our activities, do it for the rest of the year. And as you know, we are heavily funded by our fundraising activities, in particular, the Relay for Life, which did not take place this year. And so I appeal to all to continue to be members of the Cancer Society, and I wish to thank the doctors who today have decided to again contribute their time to put on this symposium. Society, whilst being handicapped by the coronavirus, we pivoted and we delivered a number of symposia throughout the year and interactions with our members and the community at large through the technological platform as we're doing this morning. I just want to remind ourselves of the fact that prostate cancer for many years has been a big challenge for Jamaica. In particular, a population that is 90% of African American heritage, or African heritage, where there's a higher incidence of prostate cancer among that subset. And when you put on top of that local taboos and perceptions, men generally did not want to be screened for prostate cancer. Things changed around 2000, 2001, 2002, 2003, when General Schwarzkopf, the famed general who invaded or liberated Iraq at the time, came out and shared with the world his diagnosis of prostate cancer. In Jamaica, we had our former Prime Minister, Michael Miley, also sharing with the community that they were diagnosed with prostate cancer. Arising from that, and changing our approach to communicating prostate cancer to the public, where we not only spoke to the men, but their families. We have seen increased numbers of men availing themselves of prostate cancer screening, and hopefully by so, and well, we know that by so doing, they would have made a decision that could impact their lives going forward. Today's topics have been curated to give the participants broad information on diagnosis, treatments, possibly prevention of prostate cancer. I want to thank you all for being a part of this program. Thank you for adopting and pivoting as well to this medium. And I wish for the symposium every success. Back to you, Dr. Wall.
Okay, thank you, Mr. Jarrett, for those opening remarks. I've used this second opportunity to welcome everyone. I've seen quite a number of persons have just logged in. We have lined up for you an expert panel to speak to us about prostate cancer. As September is globally dedicated to prostate cancer awareness, very important topic. So Without further ado, our first speaker is Warren Chin. He's a consultant urologist, achieved his MBBS and Doctor of Medicine here at University of the West Indies. He currently practices at Kingston Public Hospital and Island Medical Specialist. Interestingly, he's an avid lover of sports, specifically any game that has a ball. And today, his greatest achievement is marriage to his wife, Dr. Sherry Chin, and having 2 children. He will speak to us today about screening, diagnosis, and staging of prostate cancer. Welcome, Dr. Chin. Over to you, sir.
Morning, everyone.
Can I get screen share?
Yeah, sure. That's right.
Let's try this again.
All right, one share.
Yeah, I'm trying to screen share. I can't share. It says forced to disable.
Earl, you're currently the host. Can you pass on that to Dr. Chin, please?
Okay. All right. I'm assuming you can see the slide now. All right, morning, everyone. All right, my topic for the next few minutes is prostate cancer screening, diagnosis, and staging. Now, first of all, let me begin by saying thank you for the efforts of the Jamaica Cancer Society for the continued battle that they wage against cancer, not just prostate, but all the malignancies here in our island nation, and to the Jamaica Urological Society for giving me the opportunity to speak. Now, thinking about this topic, it's a lot to cover in a short space of time. The aims of my talk will be to discuss the rationale of early detection schemes for prostate cancer screening, why we do it, what are the current recommendations for prostate cancer screening, as in which men we're interested in screening, so the why and the who for early detection schemes. We'll also describe how prostate cancer is diagnosed, how we make a diagnosis, which is pretty much a prostatic biopsy, and we'll also give an overview as to the modalities used for prostate cancer staging, how we assess how much disease is within the body. Now, I gave this topic last year and I thought to myself, well, what's new for 2020? And no surprise, the first thing on everybody's mind is our brand new global pandemic. We have 32 million cases currently and we're approaching 1 million fatalities. And everybody has been paying a lot of attention to the current happenings with COVID-19. And normally our island nation is insular from a lot of the other things happening around the world, but even in Jamaica, you can see these maps being published every day. And if you tell people you come from Kingston and St. Andrew nowadays, they give you a little bit of a sideways look based on COVID numbers. So it is an everyday concern here in Jamaica as well. The ministry has been telling us that COVID is not over, but in September here, it is important to remember that despite COVID being one of the prevalent new diseases, prostate cancer. So with that, screening, which is defined by the World Health Organization as the identification of unrecognized disease in apparently healthy, asymptomatic individuals. Patients always come in and ask, well, what symptoms of prostate cancer should I look out for? What should I be worried about or concerned about if I have this disease? And in truth, ideally, you don't want to have any symptoms of disease. What you want is to be detected at the asymptomatic stage, generally because if you have symptoms, it usually signifies that you have a high volume or high burden of cancer to create symptoms. The symptoms of merit that we're concerned about include blood in the urine or hematuria, difficulty passing the urine, which sometimes can be overlapped or confused with benign enlargement of the prostate, blood in the ejaculate or hematospermia, bone pain when you have advanced disease and bone metastasis. And if somebody has a heavy burden of disease, you can have weight loss, lower limb swelling, etc. In general, symptomatology from prostate cancer is a late occurrence and ideally to be avoided. All right, so thinking about COVID and thinking about the world and everything else and all the diseases that affect the world, you realize that we're all in this together. I put up this slide. I don't know if you can necessarily read the inset. It's not really an important part of it. So from Globocan 2018, right, this is the world map. Now, all the countries shaded in green represent those where the leading male cancer is prostate cancer. So you can see here a lot of Europe, pretty much all of West Africa, an entire Western hemisphere has in terms of its incidence, prostate cancer being the leading cancer diagnosed in this part of the world. And on a more grim note, not just the actual incidence or the number of men being diagnosed with prostate cancer, you have to pay attention to what the ultimate effect or impact is. So on this graph, you see our age standardized mortality rates, same Globocan data from 2018. And the deeper the shade of red indicates the higher the rate of mortality, with the deepest color being pretty much over 20 per 100,000 age standardized ratio years for men. Now you will notice again, West Africa is fairly deep red, and then you see all of the Caribbean islands with the Afro-Caribbean descent genetics, all are represented with the highest rate of prostate cancer mortality in the world. Speaking specifically to Jamaica, because they were most concerned about our island nation, cancer does create a lot of pain and suffering and mortality locally. So when you look at our current cancer profile from the WHO, estimates from 2018 are that we lost close to 5,000 of our fellow citizens from cancer-related deaths. And this is not just a male graph, this includes breast, cervix, colon, uterus, etc. And if you look down here on the mortality figures, you can see that prostate cancer on the bottom right is pretty much double in terms of the mortality rates of all the other malignancies considered. So we do see a lot of men with prostate cancer, and unfortunately, prostate cancer does take the lives of a lot of our men. So why screen? So screening has to do with altering the natural history of disease. Now this graph, it's an old graph, but we continue to look back at it. If you can imagine, the red line indicates the volume or burden of disease. Ideally, what you want to do is diagnose disease here when it's just a few cancer cells, when the patient is asymptomatic, when they have no metastasis, and can institute treatment to essentially get them off this curve where the disease does not progress and does not put their life at risk. So screening, you want to identify your at-risk population, right? You want to examine them systematically to check for the disease, with the aim being you want to decrease mortality, that's to save lives, and do it in a manner that's effective while preserving their quality of life. Ideally, this is best done with early detection, right? For prostate, like many other diseases, early detection allows for easy treatment or easier treatment and more durable effects. Two caveats of importance with prostate, right? It is a disease that comes or increases with increasing age, and it does represent a spectrum of disease. Not all men with prostate cancer are at the same risk from their cancers. And I think that will be borne out later in some of the talks. So how do you conduct screening for prostate early detection schemata? Urology is typically very simple. You do two things generally. You do a PSA measurement, which is a blood test, take a blood sample, and you do a prostate exam. I personally don't like the term digital rectal exam. I'm examining the prostate. You can actually feel the prostate for lumps or bumps or nodules. And you, with these two maneuvers, identify which men in your at-risk population you want to go into further testing. So just clarifying what the PSA is. PSA stands for prostate-specific antigen. It's an enzyme, glycoprotein produced by prostatic cells. It gets into the plasma and is measurable in the plasma. And for those men with elevated levels of PSA, they're found to be at increased risk. And if your PSA levels are abnormal, then you and your urologist or your physician discuss consideration of a prostatic biopsy. That's the next test in line. For the prostate exam, it is not really a standalone test. It usually is used in conjunction with doing your PSA to assist in determining who should get further testing. Right? When you have an elevated PSA and your prostatic examination is abnormal, it does typically indicate a higher risk of not just prostate cancer, but a higher risk of more aggressive cancers. Only a few circumstances nowadays, fortunately, where we'll find men who have very suspicious prostate examinations with low PSAs that we think need to undergo biopsy. And typically these are the men with the most aggressive disease. The ultimate aim by doing early detection is that you catch the disease early, leading to increased cancer diagnosis at the organ-confined stage when the cancer is only within the prostate and has not spread yet. And by detecting men with disease that has not become advanced, you can save lives. Somebody's unmuted. Right. So in terms of proof of principle, there have been some large studies conducted internationally that essentially have shown in the majority that prostate cancer screening or early detection schemes can reduce mortality from the disease. The most quoted is a European study, ERSPC, which showed a 21% long-term reduction in prostate cancer mortality. The Americans tried to conduct their own study, PLCO, but because so many men in the US are actually getting PSA tests, this study was watered down and did not achieve the desired effect. In terms of mortality rates, what has been clear in North America is that with increased PSA testing, cancer mortality rates can be taken over and brought down. The US has managed to bring down their prostate cancer mortality rates by a whopping 51% since 1993. They had a slight elevation after 2016, and this is probably on the background of one of their expert organizations recommending against PSA-based screening. So you can decrease mortality. Referencing back to the European study in terms of those who know a lot about screening protocols and programs, the longer the follow-up that has gone on for prostate cancer screening, up to 16 years, the effect in terms of reduction of mortality has been maintained over 20%, and the performance characteristics in terms of the number of men that need to be invited for screening and the number of tumors that need to be detected to save a life from prostate cancer are actually improving, somewhat better than breast with these figures currently. I'll mention additional tests, even though I don't have the time to go into them in detail. For some men who are found to have an elevated PSA or abnormal prostate exam prior to undergoing a biopsy, on occasion you may add additional tests to try and discriminate who really needs a biopsy. Or for men who have had one biopsy that is negative, you can apply tests to see if they really need a second biopsy. Locally, we do have the free PSA measurement or free to total PSA. We do have multi-parametric MRIs. You'll see a lot of other tests which are not currently on the ground here in terms of 4K scores, prostate health index, etc., which can add in terms of biomarker assessment some amount of information as to who needs further testing. All right, so in terms of identifying your at-risk group, there are lots of international organizations that will tell you what to do, which men to test, when you should start testing, when you should stop. The important part of this slide is this part that's highlighted. American Urology Association says we should have shared decision-making between the doctors and the patients and consider beginning testing 55. However, higher risk groups, such as men of African descent, may start younger. European Association of Urology says well-informed men should consider testing at age 50 once you have a good life expectancy, and for higher risk groups, they can start at 45. NCCN is the National Comprehensive Cancer Network. They say the doctors and the patients should have a risk-benefit discussion and consider starting at 45 up to 75. However, if you have African descent or African genetics, you may consider starting at age 40. Locally, we say we can offer testing to our men beginning at age 40 and extending out to age 75 with the knowledge that we're 90% of African descent. The point of this slide is that you don't just go and start PSA testing. You should really discuss with the patient what the risks and benefits of this testing are. In terms of interval, this has come up recently in some of the expert panel recommendations in terms of maybe we can extend interval testing or lengthen interval instead of annually, especially for men, younger men with low PSAs, that you can stretch the interval instead of annually to 2 to 4 years. The truth is, locally, we do run relatively high PSAs. And if you read the inserts for all these recommendations, they do put caveats to say high-risk populations, such as those with family histories or African genetics, you really should consider yearly testing. So personally, I'm going to stick with annual testing for my patients. So how do you make a diagnosis? Essentially, the diagnosis for prostate cancer is made under the microscope. It requires a biopsy sample. You actually sample the prostate with a core needle, send this to the pathologist, and under the microscope, they look and say if they have cancer glands, yes or no. Occasionally, we can start patients on treatment who have classic metastatic disease, very high PSAs in the thousands, and classic bony mets, etc. So doing a prostate biopsy, which is the diagnostic test, is fairly simple. You put in a small ultrasound probe in the rectum. It shows you a map of the prostate, base, apex, and you can go and do a standard 12-core biopsy sampling, which is done on an antibiotic prophylaxis with local anesthesia. It's not a terrible examination or test. Do these tests 12 to 15 of them at KPH in a week, and we're typically discussing how the crops are going with the patients, etc. Significant complications are single-digit percentages, and most of them are infectious, right? And the biopsy is done either transrectally or, on occasion, transperineally. An adjunct to this has come along with increased utilization of MRI technology. MRI has been used in terms of prostate cancer staging, and then we found out with additional protocols with diffusion-weighted imaging and contrast enhancement, you can actually see tumor nodules within the prostate. All right, there's a standard way that the radiologists report these MRIs, and essentially for lesions that are deemed to be significant risk of disease, if you do an MRI before the biopsy, you can actually know where in the prostate you want to target, either with what we call cognitive fusion. You aim the biopsy cores or increase the number of biopsy cores in that region to ensure you pick up lesions, etc. Internationally, MRI targeting has become a bit of a hot button topic because it may improve our diagnostic capabilities, where you target lesions that you see on MRI, plus or minus doing the standard 12-core systematic biopsy. This has been driven primarily in the UK. MRI targets do tend to pick up more clinically significant or more aggressive cancers with fewer biopsy cores, and it may miss what's classified as more indolent or low risk, or some people call insignificant cancers. There is a false negative rate, and I personally am a little cautious in utilizing their schema, because I think in our population, we're relatively high risk and you have to choose carefully. Suffice it to say that in Europe, this is the UK expert panel and European Association. They have put out now for men who are considered relatively low risk. If your MRI is negative, you may want to omit biopsies. Personally, I think we're young in this in Jamaica, and our population is relatively high risk, so I would tread relatively carefully on this. So you do a biopsy. The biopsy sample goes to the pathologist. They look at the glands under the microscope, and they say, are these cancer cells or cancer glands, yes or no? And they issue a score, which has now become a grade group. And the higher the number, the more aggressive the disease, and the more aggressively you want to treat it. So once you've had a biopsy saying that you have prostate cancer, the next thing you want to figure out is how much disease is there within the body, because that determines how you treat with the patient. And that's called staging, assessment of the burden of disease. Now, primarily, prostate cancer staging is done with the prostate examination and the PSA level. Local staging is primarily based on the prostate examination. And if you think the patient's at risk of having disease that has escaped the confines of the prostate, you can do imaging to assess for bony disease, lymph nodes, local spread or extension beyond the prostatic capsule, and rarely visceral metastases. So local staging, you just feel the prostate and see if they have a tumor that's either not palpable, or you can feel it, or tumors that have extended beyond the confines of the prostate, and you give a local score up to T4, which is invasive disease to surrounding structures. You can do imaging studies to check for lymph nodes or distant spread, so N1 or M1 disease. These are patients that are considered metastatic. So you don't need to remember this slide essentially, but when you plug all that information in, you get a risk group for the patient, whether it's low risk or very low risk disease or very high risk disease. To put this up to show you that this is that the higher the risk, the more you want to consider bone imaging or axial imaging to look for lymph nodes, etc. in the higher risk groups. Bone scans are used for patients deemed to be at increased risk of having metastasis. 99 technetium labeled bone scans are typically used. And in this patient with a relatively high PSA, you can see increased bony activity within the axial skeleton, indicative of metastatic disease. Generally, when your PSAs are low, bone scans will be negative. CAT scans or CT scans do provide good anatomic detail, but it does take a lot of cancer outside of the prostate to be visible locally on a CT scan. But CTs do show you good detail for nodal or visceral disease. Generally, we're not using CT scans to look at tissue detail for the prostate. When you want to look at the prostate to look for tumor nodules and whether it is local or extraprostatic disease, currently multiparametric MRI rules in terms of local staging, and it does give you equal detail to CT scan for detecting lymph nodes, etc. What's probably coming more to the future is positron emission tomography or PET scans. You can use functional isotopes, C-choline, flucyclovine, and PSMA. This is coming North America, that's in Europe and Australia. These are avid tracers for prostate cancer activity, and with application combined with a CT, you can get these pictures which may show you areas within the body involved with disease, typically an assessment for recurrence. We still use plain X-rays, but usually this is for gross metastatic disease. It takes more than 50% destruction of your bone mineral to give you a positive X-ray. Unfortunately, we still do see quite a number of men with X-rays like this with gross sclerotic metastasis. And sometimes we just use an X-ray to confirm the presence of metastasis. So in summary, prostate cancer in Jamaica remains very prevalent, and it is unfortunately still a lethal disease to our men. We know that screening detects cancer at an early stage, and all the evidence points to its ability to save lives. And if you catch it early, it is curable. All the information internationally can be used locally to improve how we biopsy and stage our patients. And it's important as local practitioners that we tailor what information and tools are there to fit our population and our circumstances. Thank you.
Okay, thank you, Dr. Chin, for agreeing to be our opening batsman. You have knocked it out the park for 6. And since a lot of other persons have now joined us, I'll quickly say thank you for coming out on a Sunday and logging into our symposium, Prostate Cancer Awareness. It is brought to us by the Jamaica Cancer Society, Guardian Group Foundation, and the Jamaica Urological Society. Also, I'd like to remind the audience, if you have any questions, please type them into the Q&A tab at the bottom of your screen, where I will pose them to the respective speaker at the end of the first session. So our next presenter is Robert Wan. He needs no special introduction. He's well renowned and respected in the Caribbean as a consultant urologist and mentor to a lot of us locally. And we welcome him and thank him for agreeing to present yet again at our conference. Dr. Wan practices currently at the Winchester Business Center. Dr. Wan, please speak to us on can you prevent prostate cancer?
Okay, thank you. Okay, there's sound on the slide.
Oh, just speak to the slides because I think once you go through, it should come through.
Okay, thanks again for inviting me to address this session. Okay. So am I good now? Okay. So when we think of prevention of just fixing this on. Okay. Okay, is everyone hearing me now?
Yes, hearing you, loud and clear.
Okay, so I'm going to try to answer some questions that I get asked fairly frequently. So firstly, patients want to know how they can prevent from ever getting prostate cancer. But in my practice, even more frequently than this, are the men who have had abnormal PSAs, or maybe they have had a prostate biopsy and it showed something like HGPIN and ASAP. These are not cancers, but they can progress to cancers. So you want to do something about that. And then there's an ever increasing group of men who have been diagnosed with prostate cancer. And as you may hear, they have decided not to do surgery, not to do radiation, but to opt for what we now call active surveillance, which is reasonable for a lot of men. And they also want to know what's going to prevent them from progressing to develop cancers which need treatment. And then lastly, we have this, again, ever increasing group of men who have had treatments, and then for whatever reason, cancers recur, and they now want to know what can they do to prevent getting serious complications. So it's a very important topic for our men. So what causes cancers? We now know that it's due to mutations, that our DNA really programs our cells to divide and multiply. But for whatever reason, and some of these may be inherited mutations, such as what's called the breast cancer gene. And if men have members of the family who have this gene, then they are at risk for getting very aggressive cancers. And those men just need to be screened very early. But there are mutations which arise for whatever reason from external forces. Maybe it's lifestyle, and maybe it's their diet, or maybe it's just plain bad luck. So this is a paper that came out a few years ago. And what the researchers did was to make a calculation to see what proportion of our cancers could be due to environment and maybe preventable. And then they said only 1/3 of these cancers are due to environment, and most of the cancers are due to bad luck. But not many of us really believe this. We still think we should try to prevent cancers. So here's a study that came out again a few years ago. And what these researchers did was to try and find what happened if you really lived a healthy lifestyle. They looked at women from the nurses' health study and mainly men from the health professional follow-up study. Should caution you that these were done in a white population, and they didn't particularly look at prostate cancer. However, a healthy lifestyle for them was guys and ladies who didn't smoke, hardly ever drank, they were not too fat, they were not too skinny, and they exercised. And of course, the unhealthy lifestyle was those that did none of these. And what they found was that approximately 20 to 40% of cancers could be prevented with a healthy lifestyle. So that's the kind of thing we need to concentrate on. So what about vitamins? Here's an interesting study done in Finland. A lot of people were smoking in those days. So could they prevent lung cancers given vitamin E and beta carotene? So when they analyzed the results, they really did not prevent lung cancers. And in fact, in the beta carotene group, there appeared to be an increased risk of lung cancers. But what about prostate cancer? As a unanticipated finding, they found that prostate cancer was reduced in the men who took vitamin E. So should we all take vitamin E? Well, here's a sensational headline that came out some years after that. Why vitamin E is dangerous for your health. Why? So this is a study called the SELECT study. It was supposed to be the study of all studies for vitamin E. And what was done was to put men on selenium, vitamin E, both, and see if these prevented prostate cancer. The study was actually stopped at a very early stage after 5 years because it became apparent that there was no reduction of prostate cancer in the vitamin E group. And in fact, there was a concern that men who took vitamin E appeared to have an increased risk of prostate cancer. So what about zinc? A lot of my patients ask, well, we're going to take zinc because we know that the prostate needs zinc, and that certainly is true. The prostate gland has a high concentration of zinc. So again, from the health professional follow-up study, zinc supplements were used, but the finding was that zinc did not prevent prostate cancer. In fact, there appeared to be a risk of having advanced cancers if you took zinc. So I don't recommend zinc. Vitamin D is interesting. We all know vitamin D is very useful. So this is a study. It's still going on, actually, the VITAL study. They're using vitamin D and fish oil. And the purpose of the study is to see if vitamin D would lower the risk of cancers or heart disease. So far, it doesn't seem to be doing anything up to 5 years, except for prostate cancer. There appears to be a slight reduction of the incidence of prostate cancer in men who take vitamin E. And this we should note because the effect was noted mainly in the Black population. So this is something we're going to keep our eye on. So prescription drugs, a lot of our patients take finasteride and dutasteride. These are available in Jamaica as some would know it as Proscar, Fincar, Avodart, Duodart, and maybe other names. The original one was finasteride, or Proscar was the company that produced it, Merck. And what they found, if you compare people who took finasteride versus those who did not, that there was a 25% reduction in prostate cancer. But when the companies try to get FDA to approve these drugs to prevent prostate cancer, their application was turned down. And this is because there was an unexpected finding of higher grade prostate cancers in the men who took finasteride. Now, the reason for this is unclear. The drug companies say, okay, you're finding higher grade cancers. But you know what? It's because we're shrunking your prostate glands with the drugs, and therefore the cancers are easier to find. Another possible explanation is that maybe these drugs really prevent the low-grade prostate cancers and not the high-grade. So we do not use these drugs to prevent prostate cancer, but we use them in men with enlarged prostates who have difficulty avoiding, and we still use a lot of it. So metformin is interesting because a lot of Jamaicans are on metformin, and this is just one of the studies that show that maybe metformin could reduce the course and incidence of prostate cancer. In fact, some workers are saying, well, why not give everybody with prostate cancer metformin because it's a relatively harmless drug. So here's another one that's interesting, statins, and these may work through the cholesterol metabolism or reducing the activity of testosterone. And again, statins have been shown in some studies to reduce the risk and the incidence of prostate cancer. I should caution you that they are not approved. Metformin and statins are not approved for prevention of prostate cancer. But we should encourage people who are taking these drugs for their elevated cholesterol that they should, and for diabetes, should continue to use them. So this I get asked very commonly, and it's more the Guinean weed than the other one. My patients, they used to boil the leaves, they used to boil the roots. Now they seem to be buying a capsule or a tablet. It's a big stretch to go from having a product that we think could, cure cancers, and then proving that it works in the lab, and then proving that it works in lab animals, and then showing that it works in patients. So there's no proof as yet that Guinea hen weed either prevents or cures prostate cancer. But I don't discourage patients from doing it, because we all need to know that we are doing something, and as long as it's harmless, that's fine by me. So let's look at alternative medicine. And this was a study done in the USA a few years ago, where they looked at people and to find out if they believe that alternative medicine could work. It seems that, especially in the young adults, there was a strong belief, over 40% belief, that alternative medicine alone can cure cancer. So what really happens in real life? So here is a study published a couple of years ago, and what they found was that people who used complementary medicine had a greater risk of dying of cancers than people who use conventional medicine. And the same was for alternative medicine. This is the same group of workers. They looked at people who use alternative medicine and compared them with people who use conventional medicine, and found that those who use complementary alternative medicine had a much greater risk of dying of cancers. Now, the reason for this is not because of the complementary alternative medicine. The reason for this is because people who use these types of treatment, they really ignore or don't use conventional medicine such as surgery, radiation, chemotherapy, hormonal treatment. So my takeaway from this is that if you ignore your doctor's advice, then you may be getting into serious trouble. So this is the fun part of it. We've been looking at the possibility of how sex relates to prostate cancer. And this is just one of the studies that show that men who had sex very often, this is ejaculating 20 times a month versus those who are only doing it 5 times a month, had a lower risk of prostate cancer. The poor guys who didn't have sex at all had a greater risk of dying from all causes. And this was done in a health professional follow-up study. The only thing about this is that most of my patients are in their 60s and 70s. And for you to benefit from this, you would have had to have that increased sexual activity from your early 20s. So, acne. There's a lot of phobia about acne. I haven't seen any proof that it causes prostate cancer. And my message to my patients is the same that the great Dan Christian told me this many years ago, that everything in moderation, nothing in excess. So sausages, salami, bacon, they were labeled as carcinogens several years ago in this report, because they felt there was a greater risk of cancers, especially colorectal cancers, due to these processed meat. And in fact, they also labeled red meat as a possible carcinogen. So we need to reduce our red meat and stop the bacon and sausages. Grilled meat are especially harmful because, especially if they're cooked at a high temperature, so these two substances, heterocycline, amines, etc., they may cause damage to our DNA. And as we've said, that is one of the things that causes cancers. My patients all tell me that they know that tea is fine and green tea is even superior, and that's true. So they now say, what about coffee? And I tell them coffee is fine, it doesn't do anything to prostate cancer, and people who drink coffee, in fact, appear to be able to live longer. So finally, my recommendations to all my patients: look, stop smoking. If you're gonna drink, you don't have to drink. Keep it down to 1 or 2 drinks a day if you're a male. And you should get to Emancipation Park and do several laps every morning, at least 5 days a week. Don't put on too much weight. Watch your dairy intake and reduce your red meat intake. Watch that jerk pork. So they don't say, well, what's red meat? And the answer is very simple. It's anything that comes out of a mammal. We like people to have fish. We like people to have poultry, which is chicken. If you're in North America, maybe turkey. And of course, you increase your vegetable intake, such as broccoli and tomatoes. Don't ignore brown provisions. Reduce the refined starches. Refined starches is really white flour and red meat. So finally, I'd like to thank everybody again for being patient enough to listen to me this morning, and I thank the organizers again for inviting me. And remember, guys, we need to get your PSA checked. Thank you.
Okay, thank you, Dr. Wan, for another excellent talk that you've come to expect. Speaking to us there about some of the environmental factors affecting prostate cancer and prevention. So, to not smoke, eat healthy, don't get too obese. And I noticed that you did not recommend at the end for the younger guys to ejaculate more frequently. All right, so we have another presenter, Gareth Reed. He is a consultant urologist at the University Hospital of the West Indies, and he will now speak to us about the genetics of prostate cancer. Welcome, Dr. Reed. Good morning. Over to you.
Good morning, Dr. Wang. Thank you very much for your introduction. I'm just trying to get my slides going here. One sec. Okay. Good morning, everyone. I'd like to thank the Jamaica Cancer Society and the panel for inviting me to give this discussion on genetics in prostate cancer. This is, or the thought of genetics in cancer management in general has become very, very popular, or very cutting-edge discussion with regards to treatment of prostate cancer, or treatments of any cancer really, and the identification of different cancers and how to apply these genetics in the management or the general management of varying cancers, prostate cancer being one of those. Now, the problem with genetics, and when most physicians or even patients hear the term genetics, you picture quite a complex set of complex information to digest, and a lot of the times we kind of shy away from it. I'm going to attempt to, in a brief period, discuss genetics as it relates to prostate cancer and show that it's probably not as complicated as we think it is, and it's something that we can apply in our general practices here in Jamaica. So my general outline is I'm going to go through it in a most basic form in terms of some of the basic concepts. I'm going to introduce the terminology, germline testing, and then go into some of the indications for genetic testing, as well as some of those potential applications that we can use. And finally, discuss some of the dangers of genetic testing. So where did all of this begin? It really became possible with the Human Genome Project, which essentially began for about 13 years between 1990 and 2003, where all the base pairs in the human genome were mapped, about 3.2 billion base pairs. That being said, I mean, most of us heard in passing about the Human Genome Project, but really didn't become, or the use of genetics really didn't become a significant issue, interestingly, until about 2013. And this is where the concept of genetic testing and genetics was essentially introduced to the world, where a popular actress, Angelina Jolie, announced to the world that she had undergone bilateral prophylactic mastectomy because she had been detected with this gene called the BRCA gene that was shown to increase the risk of breast cancer. So she said that essentially she had decreased her risk from 87% to under 5% of developing breast cancer just by doing a double mastectomy. And what occurred after that is in the same year, there was a 40% increase per week of BRCA gene testing in America. So this is a concept of, or this is, the concept of germline mutations versus somatic mutations. So we're going to be focusing on germline mutations. And all that essentially means is from the combination of egg and sperm, the embryo inherits the mutation, and therefore the entire organism will carry the mutation. So germline mutations essentially just speak to when your parents can pass on these abnormal genes to you. And similarly, if you have the gene, you can pass it on to your children, as opposed to somatic mutations, which we're not going to get into a lot in this talk, but somatic mutations just essentially mean that it's a patch of an area within the body that inherits these abnormal or gets these abnormal genes, and you do not pass it on to your children. So most prostate cancer, as mentioned before, is not of a genetic basis. It tends to be sporadic, and about 70% of all prostate cancers occurs with no known cause, and there's no increased risk for family members, and there's no specific mutation found. There is a familial component, which makes up about 15 to 20% of different cases, where there's no detectable genetic mutation, but it's thought to be due to some kind of genetic and combined environmental risk. So close family members will be found to have an increased risk, but you don't essentially pick up any specific gene. The hereditary version, and that's what a lot of this talk is going to be on, is looking at about 10 to 15% of all cancers due to a single inherited gene, and there's a significant increase in lifetime risk. And some of the popular ones for prostate cancer include BRCA2, BRCA1, as well as some of the Lynch syndrome, mismatch repair genes, and another one called HOXB13. And this is a basic model of cancer development, not necessarily related to prostate cancer, but what you have is a cell with a single gene mutation. You get increased growth, an abnormal growth, and eventually it leads to cancer. So in terms of hereditary tumors, as I mentioned before, about 10 to 15% of prostate cancers are hereditary. If you have an abnormal gene, it doesn't necessarily mean you will have cancer, but it does increase the risk of developing cancer. These genes interact with other genes as well as the environment to increase the risk of development of prostate cancer. But it's not only prostate cancer, there tends to be an increased risk for some other cancers such as breast, ovarian, and pancreatic tumors. These are currently the most studied genes with regards to development of prostate cancer. It's about 15 of them, and I've highlighted a couple of the more common ones. So BRCA2, BRCA1, and we speak more about those. And these tend to be based on what we call DNA damage repair genes. And I'll show you some slides later down with regards to how these DNA damage repair genes affect the possibility of developing prostate cancer. As you can see there, the prostate cancer risk is about 20% with a BRCA1 or 2 gene. And I've also mentioned one called HOXB13 that I've also highlighted in red, where you have about up to a 60% prostate cancer risk increase. And this is the one that tends to be found in men who develop prostate cancer at a very young age. So let's talk about the BRCA1, BRCA2 mutations on prostate cancer. So these are DNA damage response genes. Essentially, what you have is mutation of these genes leading to genetic instability and increased cancer risk. The lifetime risk with a BRCA2 versus BRCA2 gene mutation is about 2.6-fold increase in the development of prostate cancer. By the age of 65, you have about an 8.6-fold increase in the risk of prostate cancer. Not only is it that you have an increased risk of developing prostate cancer, but that prostate cancer is likely to be more aggressive. So it's very high Gleason grade, so Gleason 8 or higher. It may present or tend to present with metastatic disease, have node positive disease, and it's been shown to have poor survival if you do develop prostate cancer with one of these mutations. In a large study looking at, or probably the largest study looking at these germline mutations in men with metastatic prostate cancer, it was found that in men with metastatic prostate cancer, up to about 11.8% of them were found to have germline mutations. And if it is that you did have this mutation, BRCA2 was found in about 44% of these patients. So when is it that we do genetic testing? Sorry, when is it that we do genetic testing? There are three main categories of, in terms of when you're looking at doing genetic testing. So there's a category for when you have men with metastatic disease, men who are just diagnosed with prostate cancer, but it hasn't spread, or men who do not have a diagnosis of prostate cancer. And I'm going to go into each category as we go along. So with regards to men with metastatic prostate cancer, this is a very clear indication that all men with metastatic prostate cancer should consider genetic testing. It identifies variant hereditary cancer syndromes. It allows you to inform potentially your children, your family members about the potential for them having an abnormal gene, and therefore it may mean that they may need to get tested earlier. It also may aid with some of the newer drugs that are essentially targeting these abnormal genes for treatment, such as something called a PARP inhibitor. And we're going to go into that in a little bit. So a PARP inhibitor is something called a poly-ADP ribose polymerase inhibitor. Please don't try to remember that word. Essentially, everybody just calls it a PARP, P-A-R-P inhibitor. And I'm going to go into this briefly here, but the BRCA gene essentially helps to repair damaged DNA. PARP, the PARP also causes repair of your DNA. So if it is that you have BRCA1 being normal, your PARP being normal, then the cell will survive. So if it is that this is a cancer cell and the cancer cell DNA was damaged, and you have both the BRCA1 and PARP gene present that fixes the DNA damage, and the cell will survive. If you have a BRCA mutation, but you still have your PARP intact, the PARP will fix the DNA and you'll have cell survival. If you have BRCA gene intact, but you now use a PARP inhibitor, the BRCA will still go ahead and fix the gene. But if you now eliminate your BRCA, if you have a BRCA mutation as well as a PARP inhibitor, then the DNA cannot be repaired and it will lead to cell death. And I know that sounds confusing, but I'm going to go into it a little bit later on. But essentially, there are two new drugs approved by the FDA for use in men with metastatic prostate cancer, which are olaparib and rucaparib. For men who do not have metastatic prostate cancer, so it has not spread to the bone, but it just remains localized within the prostate, it can aid in diagnosing, doing genetic testing in these men can aid in diagnosing other hereditary cancers. It can help to inform family members of their potential risk. And interestingly, for men with prostate cancer who are considering no curative treatment and are on something called active surveillance, which we'll probably discuss later in the talk or in someone else's talk. We are looking at men who now we don't necessarily go ahead and give formal treatment, but you're essentially observing the cancer very closely with a plan to attack if it is that you do develop any changes. Now, genetic testing has been shown, so the presence of one of these abnormal genes has been shown to give you a higher chance of failing active surveillance. So there's a chance that you can have an upgraded biopsy if it is that you have early localized prostate cancer with a BRCA2 mutation. So basically we're considering, there's strong consideration worldwide that if you're putting a man on active surveillance, you could consider doing genetic testing to see if it is that they have a mutation, because this might tell you that this is not the candidate to continue with active surveillance, because there's a chance that they may get upgrading in terms of their biopsy and become metastatic afterwards. For men who have not yet been diagnosed with prostate cancer, this remains an evolving area. Yes, there is the potential to screen for other at-risk cancers such as breast, ovarian, pancreatic cancer, whether in the family or in the patient themselves. May also give you an idea that you may need to consider changing your screening protocol. So you're going to start earlier. So you should consider being screened as early as age 40 with annual follow-up, regardless of race or any other high-risk factors that you are aware of. And these are the current guidelines by the National Comprehensive Cancer Network out to the US. So all men with metastatic prostate cancer should undergo genetic testing. If you have a family history of a high-risk germline mutation, such as BRCA1 or 2, if you have a strong family history of prostate cancer, so your first-degree relatives, brother or father, or multiple family members who were diagnosed at a young age at less than 60 years of age. If you have one or more close relatives with breast cancer at age less than 50, or ovarian, pancreatic, or metastatic or intraductal prostate cancer at any age. If you have some of these abnormal pathologies, such as intraductal or cribriform prostate cancer, which are pretty advanced, or if you have a Ashkenazi Jewish ancestry. So onwards to some of the more practical things. If it is that you fulfill one of these criteria, what do you do next? You should undergo informed consent. So you should have a long discussion with your physician, so whether it's your oncologist or urologist or your general doctor, about what is the purpose of genetic testing, what is it that you hope to find and what to expect. You must be aware though that there's a potential to uncover other hereditary cancers or syndromes that were very unexpected, or the potential risk of these things that were unexpected. What do you do if the results are abnormal? What exactly does it mean? It doesn't necessarily mean you will develop cancer, but it does mean that you have an increased risk. What are some of the costs involved? Is there any potential for discrimination based on the results? And then you have to consider now the potential need to test the relatives. How is testing performed? It's usually a saliva-based test, but there have some blood panels. And it's a multi-gene panel that looks for essentially almost about 60 different genes and gene abnormalities. And yes, it is available here in Jamaica. And in regards to the cost, it's somewhere around 60,000 Jamaican or $500 US. And we do offer what's called cascade testing. So cascade testing is if you are detected with an abnormal gene mutation, then the rest of your family should go in or can potentially go in for genetic testing as well to look for identification of these abnormal genes. There are, however, some dangers in terms of genetic testing. And one of the biggest ones is the anxiety and psychological impact of having an abnormal test. If you are diagnosed with a genetic abnormality at the age of 20, you're going to be thinking about this for the next many years, waiting to see if you're going to develop this cancer. And that can have a significant impact on your psyche. You must remember as well that a germline mutation does not necessarily equal cancer. It only gives a guide for the potential risk. So that is a significant issue. Another significant danger with regards to genetic testing is the potential for discrimination with regards to that genetic test. So in the US, the Genetic Information Non-Discrimination Act was done, which essentially tries to protect individuals against employment discrimination on the basis of genetic information. And it should also give you some protection against health insurance issues. At present, though, there is no protection from discrimination with regards to life, disability, or long-term care insurance. And we also have to remember that though it's written on a paper that your employer should not fire you if you're found to have a genetic abnormality, it can potentially influence them to come up with some other reason. And I'm not saying that that's what happens. It's just something that, you know, we can't be naive about. So there's a significant concern with regards to genetic testing in this setting. But what are some of the therapeutic roles with regards to the use of genetic testing? So specifically for men with metastatic prostate cancer, and this is what we spoke about earlier, this precision cancer medicine. So all cells are known to repair their DNA, normal cells as well as the cancer cells. So if there's DNA damage, then the cell dies if the genes that repair the DNA are abnormal. And in cancer, our aim is to encourage cancer cell death. So this is a similar slide to the one I mentioned earlier, so the use of PARP inhibitors. So if you look to the left here, this is a normal cell. You have BRCA coming to repair this damaged DNA, as well as the PRAP coming here just to repair the damaged gene. So if you have loss of BRCA, you still have your PARP coming in as a base excision repair to fix that DNA. So imagine these are cancer cells that you want them to die, but they keep living on because they have two mechanisms to repair their damaged DNA. In this situation, if you try to use a PARP inhibitor with somebody who has a normal BRCA, so you've eliminated the PARP, you still have the BRCA coming in to repair the damaged DNA. However, in men who have a BRCA2 mutation, this is where the PARP inhibitors have been shown to have significant response. You use your drug, the PARP inhibitors, olaparib, and the other mentioned earlier. I know you would have eliminated the two mechanisms of repair of this DNA, so there's no repair, and you have cancer cell death. So this is where you have this precision medicine being developed. What is some of the potential outlook for Jamaica and the Caribbean? Right now, prostate cancer in Jamaica, as mentioned earlier, it's we have the highest cancer-specific mortality of all the cancers in Jamaica. And interestingly, a significant number of our patients present with metastatic disease. Now, I'm not saying that we should focus on patients with metastatic disease. What we need to be doing is detecting men earlier before they become metastatic, treating them and decrease these numbers. However, men with metastatic disease, as I said, significant number of our men present with that. We now have the potential new therapeutic options, such as use of PARP inhibitors, though they are expensive. There may be a role to aid with screening discussions and early detection and active surveillance protocols in men detected with these germline mutations. And it may also help to guide families with a history of prostate, ovarian, and breast cancer to look for earlier detection to avoid the metastatic disease. So in summary, this is a remarkably evolving field that gives a lot of hope for how it is that we view cancers, how it is that we consider managing them and treatment in general. I promise you that probably over the next 10 years, there's going to be significant changes in how cancer is detected, how cancer is managed with use of genetic profiling, but it's not without risk, as mentioned. There's significant concern for potential discrimination, as well as significant psychological impact of just knowing that you have this disease, not the disease, but rather this mutation. There is a high prevalence of germline tumors in prostate cancer, greater than about 11%, and you should consider referral for genetic testing if you have patients who fit the criteria. It is available here in Jamaica. We have some significant gene panels that we look on a lot of different options, but the most critical ones for prostate cancer at present, we're looking at the BRCA1 and 2, ATM, HOXB13, and another one called CHEK2. Thank you very much.
Okay, thank you, Dr. Reed, for keeping us up to date with first world medicine and contemporary urology. We are pretty much on schedule. I see the questions starting to come in. There's a slight change in the program whereby we'll have one more presenter in this first part of the symposium. Dr. Roy McGregor. He's a consultant urologist based at Cornwall Regional Hospital, and he has a keen interest and specialty in minimally invasive surgery for prostate cancer, an evolving technique. Dr. McGregor, we welcome you and thank you for agreeing to present. Over to you.
Hello, Dean. Good afternoon or good morning, everyone. Thank you very much for inviting me to speak again. Just give me 1 second to go through the slides. Okay, so it's nice to see that everyone's we're managing to keep things going with COVID, and I've found the talk so far very good and interesting, and thank you again for inviting me to speak. My talk's going to be on minimal invasive surgery for prostate cancer, an evolving technique. Right, so what is minimal invasive surgery? The minimal invasive surgery really is performing surgery through small portholes or naturally occurring orifices. And this involves the use of an endoscope or a laparoscope to visualize the internal organs while inflating and creating the space with carbon dioxide. This is actually a picture I dug out. This is one of the earliest endoscopes. And the picture on the left, this is from a museum, Karl Storz, and they used a candle and a series of mirrors to generate light and a magnifying glass to look in. And you can see the picture to the right, which shows someone using the device. So historically, the first laparoscopic cholecystectomy was in 1986, and the first lap nephrectomy in 1991. And Prof. Eden, my mentor, did the first lap radical prostatectomy in 2000 in the UK. Advantages, they're pretty well established now. Reduced blood loss, better cosmetic result, less postoperative pain and analgesia requirement, reduced nosocomial infections, fewer immobility-related complications such as DVT, PE, pneumonia, and a shorter hospital stay and less days off sick. And this is really quite important in Jamaica, where we have a relatively large amount of people living hand to mouth, and the loss of earnings due to illness, where this really makes an impact. So disadvantages, well, it's a very flat learning curve. And so it takes a while to learn laparoscopic surgery. Initially, there's an increased cost for equipment and the procedure, and also the training of the staff and your assistant surgeon and yourself. And initially, there was a longer operative setup time, but once you have a team that's working together well, all of these things can be surmounted, which they have. So in the old days, we would do a laparotomy, then we moved to laparoscopy, and now there's some people taking organs out through natural orifices, such as the vagina and elsewhere. So open surgery, this is what it looks like. In the old days, they used to say if you were a real surgeon, you'd make big cuts. And this is laparoscopic surgery in action. And this is the advantages. This is a patient day one after surgery. He's up walking around. 20% of people will go home first day after surgery, and the other 80% on average 2 nights in hospital. So the technique, it's pretty much exactly the same port placement as for robotic assisted laparoscopic prostatectomy, but we use one less port. And it's 5 ports, small incisions, 2 5mm incision and 3 10mm incision. And the vision is excellent. This is the dorsal venous complex, and we're suturing and tying off this big vein, which is the main culprit for bleeding with open surgery. And so I'm just going to go on to the changes in the technique. Essentially, there were several steps. I started out doing a standard technique, and I did a racket handle repair, which is what is commonly done in the open method. But then we switched it to a fish mouth technique, which is quicker, and it doesn't pull the bladder neck away from the urethral stump, which can be a problem when trying to pull the bits together after you've removed the prostate. Advantages: it reduces tension, makes it symmetrical, possibly better continence. The disadvantages is that I need to bring in a special suture, but they're not that expensive. And the learning curve for that was not particularly difficult. The other change was the Rocco suture, and this is a special suture to help bring the anastomosis together under without tension. And there is some evidence that it may improve continence, and the downside for that is very small as well. Also, another major advance was when I went from interrupted sutures to continuous sutures. The advantages are that it's quicker. At the end of the anastomosis, I always leak test. And since we've shifted to that technique, almost always there's no leakage and the anastomosis is watertight. So as the technique developed, I copied essentially Professor Eden. He has published, we've published work together in British Journal of Urology International. This was a summary of 1,138 consecutive cases that Prof had done. And the end result was that the long-term results matched those, and in quite a few series, it was superior to other contemporary open and robotic series. And then this is an interesting paper. This relates everything to our population and Dr. Reed's presentation before me, in that we have a much higher proportion of high-risk prostate cancer patients. And in this publication, Prof and myself took out all of the high-risk patients. And pleased to report that at 24 months, median follow-up, continence rate was 91.8%. 6.1 had immediate continence. Potency was 64%, and this was for non-diabetic men less than the age of 70 after a bilateral nerve spare. And biochemical disease-free survival was also high. 92.4% did achieve a PSA of 0.1 after surgery. So conclusion, laparoscopic radical prostatectomy was considered a good option for patients with high risk prostate cancer. And we would suggest actually that, especially in our setting and in any setting where you're confronted with a young patient with an aggressive disease, that multimodal treatment with laparoscopic radical prostatectomy or robotic assisted laparoscopic radical prostatectomy being the mainstay of the treatment, followed by radiotherapy and hormones if required. I'm just going to touch quickly on lymph node dissection. Who should get it? Well, we normally say intermediate and high risk patients. I now use the Briganti nomogram, and anyone who is using that nomogram is expected to have more than 7% lymph node involvement. We would proceed with a extended lymph node dissection. Extended lymph node dissection is standard of care. It's in the European and American guidelines. And this picture shows a limited obturator fossa lymph node dissection compared to an extended lymph node dissection. And the long and short of it, the anatomy that we get is very nice with the laparoscopic approach. And in summary, with the extended technique, we get 92% of the lymph nodes as opposed to 56, and this has prognostic significance to the patient. The 8% of nodes that aren't harvested are those nodes in the sacral area in particular, which are where the risk benefit is such that it's best to leave those alone. And if they are involved, then you would give external beam radiation. So why extended lymph node dissection? Basically, there's evidence showing that life expectancy is increased. And this is not just increased in terms of survival, but the number of nodes harvested actually correlates with a better survival in certain studies. Also, additional benefits, we get full pathological staging, which has prognostic advantages as opposed to radiotherapy, and also it allows for early adjuvant therapy. Granted, there are some recent studies which have shown that salvage treatment actually is better than adjuvant treatment in certain subset of patients. These are the guidelines, AUA guidelines with regards to extended lymph node dissection, and these are the EUA guidelines, and plenary session when it was new, hot off the press. So laparoscopic radical prostatectomy in Jamaica, we started back in 2011. And I just want to give a thanks to Professor Eden, who without his help and his constant mentorship and visits to Jamaica on a regular basis, we wouldn't be here today. Prof has done over 4,000 cases. He does mainly robotics now. So in Jamaica, the standard of care prior to that was open radical prostatectomy with a standard non-extended lymph node dissection. First world countries, robotic assisted laparoscopic and laparoscopic radical prostatectomy are the mainstay of treatments. Very few people get open surgery overseas these days. So this series that I'm going to report on briefly is the only series of laparoscopic radical prostatectomy cases performed in the English-speaking Caribbean. The aim when I first came out was to establish a minimal invasive laparoscopic prostatectomy service in Jamaica. And the aim of the study was to review all the cases performed since arriving 10 years ago. I think actually it's coming up to 11 now. So it's a retrospective study. We got ethics committee approval. Dockets were reviewed by myself and Dr. Parker, who I'm eternally grateful for his hard work. We randomly selected dockets and checked each other as a quality control. And where necessary, patients were contacted by phone to acquire missing data. The first case was performed in 2011. It's actually a little bit more than 99 months. I haven't updated the results since March. We've actually done 128 cases now, but for the purpose of this presentation, I'll report on the 121. All had clinically localized prostate cancer as determined by bone scan, CT, and multiparametric MRI. All low-risk patients had an extra or intraperitoneal approach, and all intermediate and high-risk patients had an intraperitoneal approach with an extended lymph node dissection. Mean age was 62, mean BMI was 27, and the mean pre-op PSA was 14, range being 2.6 to 56. Medium pre-op Gleason score was 7. So in comparison to the UK, and this is Prof. Eden's series from 2014, we have a disproportionately higher number of intermediate risk and high risk patients. 16% of my series were low risk as opposed to 51% in the UK. And if you total it, 48% of newly diagnosed prostate cancer patients in Prof series had high risk or intermediate risk disease as opposed to 84% in our series, which is surprisingly high. Median operative time was 385 minutes. And I'm pleased to say that we are now consistently down to between 4 and 5 hours, and that's including all comers with varying sizes of prostates, and that is now well within a respectable time frame. And that includes doing the extended lymph node dissection, which I might add is a operation within the operation. So we're doing 2 surgeries in one. So median blood loss, if we look at the whole series, it was 300 mils. If I just look at the last third, it was 150. There were no intraoperative transfusions. Average hospital stay was 3 days, and no conversions. Mean prostate weight was 63 grams. Positive margin rate was 18.6. Prof series was 13.9 for all comers and 26% for high-risk patients. So considering we have a disproportionately higher number of high-risk patients, those figures are not too bad. Seminal vesicle involvement in 13.6% of patients, and extracapsular extension in 39. Median lymph node count was 11, and it ranged from 1 to 25. 11.4% of patients who had an extended lymph node, who had an extended pelvic lymph node dissection were positive for METs. This is high compared to Prof series of 0.8%, which is what we would expect given our population. Median follow-up time was 35 months. For continence, we excluded patients who were less than 6 months out, and 84% of patients were completely continent with no pads versus 93 and 91 for all comers in the UK. 12% of patients used 1 pad, and 4% were completely incontinent and would require a sling procedure to give back support to the sphincter. What I would like to say that the overall 60% of patients who had normal erections pre-op were not diabetic and under the age of 71, who had bilateral nerve sparing, were able to get normal erections with or without a front end lifter. And when I look at the last third of patients, this number went up to 83%. Recurrence rate was defined as a rising PSA on 3 consecutive readings. There was a 30% recurrence rate, which was the same as the UK. Complication rate was acceptable. And all in all, it's taken a fair bit of time and a lot of standing, but I think we can safely say we're through the learning curve now. And I'm quite happy to take on prostates of up to 100 grams or so. So in conclusion, although extended lymph node dissection increases operative time, it is justified by the high rate of metastatic involvement in the excised lymph nodes. Our results are comparable to other international laparoscopic prostatectomy series with or without robotic assistance. So in Jamaica, I'm pleased to say that laparoscopic prostatectomy is now a well-established treatment option for patients, and it's important that we get the message out. Thank you very much.
Okay, thank you, Dr. McGregor, for such an exciting talk. And we're pretty much on time, so we can take some questions. Well, if you follow in the Q&A tab, everyone can open it. There was a question posed to Dr. Chin about screening, and he has answered that already. And a second question was posed to Dr. Gareth Reed about the genetics, which he also answered already by typing. However, there's one more here, which is posed to Dr. Wang, and it is from Lorian Hyde. She seems to be a little bit of disagreement that frequent ejaculation can reduce the risk of prostate cancer, because she's quoting that 4 of her uncles died from prostate cancer, yet they were very active sexually. And her question is, Dr. Wan, the role for a study in Jamaica regarding this matter.
Okay, firstly, I'm really sorry to hear about your relatives, but you know, the data does show that there is a reduced chance of developing prostate cancer for those frequent ejaculators, if we may term them that, who, when they start at a young age. So the study doesn't show that, you know, the risk of prostate cancer is abolished completely. In fact, there are other studies that look at number of sexual partners. And it may be that increased number of sexual partners may actually increase the risk of prostate cancer. Although, again, the studies are not clear on this. As far as Jamaica is concerned, yes, we can do a study. The problem is really funding for these studies. You know, we apply for funds and we pay people to do the research. So that's a possibility, and I thank you for that suggestion.
Okay, thank you, Dr. Wan. There are 2 more questions that are in the chat group. So we're gonna ask Dr. McGregor. Someone is asking, what is the cost of laparoscopic radical prostatectomy? And then one more for Dr. Reed. Someone is asking, where in Jamaica is multi-panel testing done for prostate cancer? We'll allow those 2 persons to answer, please.
At Cornwall Regional, I've managed to, on most occasions, not charge the patients through getting the administration to pay for the laparoscopic equipment, or using items used in the private. I routinely parcel them together and donate it to the public. And so I've managed to keep the costs down in the public for the patient to, on average, between 50 and 100,000 Jamaican, which they have to pay to contribute towards the clips and the sutures. But I've never turned anyone away because of lack of funds. I've always managed to find them. In the private, the insurance usually covers the bulk of the surgery fees, and if ever there's a patient that is struggling, I think I can only think of one case where we couldn't come to some sort of arrangement. And you know, you give discounts accordingly. I'm sure we all do that. But long and short of it, it's about 16 to 17,000 if you do it in the private US. but that figure can vary, and if needs be, I can take that right down to by reusing equipment and stuff, we can drop that down even further. I can't give you an exact figure of how low we can get it, but we do manage to get it quite low.
Okay, thank you. Dr. Reed, someone is asking where the gene tests are done.
Okay, I'm aware of 2 locations. One is through an oncologist, Dr. Sherry Warchin at Island Medical Specialists, or through Dr. Patrick Roberts at Cunningham Medical Services on Cunningham Avenue. Those are the 2 locations that it's offered at present. Okay, thank you. I'm going to ask if you could also post that answer into the Q&A or the chat group so that others who may be interested could have access to that information. And we only have time for 2 more questions. One again for Dr. McGregor. Person is asking with respect to your last few slides, speaking about laparoscopic surgery in Jamaica. Their question is, does Jamaica boast enough surgeries to safely make such a statement? And are there cases where open surgery is more advisable?
I've never had to convert in the whole time that I've been doing these, and I've never had to transfuse anyone. Actually, no, there was one patient recently, but for this series, I've never had to transfuse anyone intraoperatively, and that's over, 122 for this and 128 in total. And my colleagues who do open surgery, and I did open surgery when in my training, quite a lot of open cases. And, even Patrick Walsh is in his hands, the average blood loss, and he's the granddaddy of the operation. He described the nerve sparing procedure. And if you look at his series, his average blood loss was about 870 or so mils per case. And it's not uncommon in an open case to lose 1 liter of blood, 2 liters of blood. And I'm sure all my colleagues would agree to that. So on a whole, the visualization, the image is magnified onto a TV screen, so you're not knocking heads with your colleague trying to peer down a deep, dark hole. And when you're doing the nerve spare, you're right up against the nerves. You can see exactly where they enter the prostate. You don't get that perspective in open surgery. And that's why everyone's doing robotics overseas. And, robotic assisted laparoscopic prostatectomy is just the extension of laparoscopic prostatectomy. So, I think in time, hopefully we can train up some surgeons so that it can be offered routinely in the public by a handful of centers. And there are several studies looking at the learning curve in low volume centers. And, it took me a long time, but, and I was lucky to have Prof who came out and we did 5 cases in a week, and he would come every 3-4 months. And it was quite difficult because, you'd have to do a lot of revision of tapes and studying to get back to where you were 3 months before. This is different now. I have a laparoscopic prostate surgery every list until November. So I think that the volume is there, and I think eventually what will happen is more people will have minimal access surgery, because why wouldn't you? And, and so then the volume doesn't become as much of an issue. And I think eventually, hopefully we get to a point where even in the public, everyone's getting laparoscopic prostate cancer surgery. And I mean, it's much better. Patients go home the next day, the day after, very little pain. I think time is the best friend of truth, and it will eventually people will, the word will get out, and hopefully we can provide a service across the island and train other people in other Caribbean countries, because I don't think we will get a robot in the public sector in Jamaica in my lifetime. I could be mistaken, but I don't think so.
Dr. Wong, a quick question. Given what we have heard this morning about the incidence of prostate cancer being greater among African Jamaicans, African persons of African descent, given that we have heard this morning about the contribution of our DNA, would it be recommended or considered for persons to do prophylactic prostatectomies, given that now that you're doing it in a laparoscopic fashion, that the patient gets home quickly, it's not too expensive?
Okay, so I'm gonna break up that question into, well, Dr. McGregor already spoke about laparoscopic. That's just how it's achieved, how to take out the prostate. But the actual indication to do what you term the prophylactic prostatectomy, I think Dr. Reed is better suited to answer that question, similarly as how he told us about Angelina Jolie. Dr. Reed, role of prophylactic radical prostatectomy?
Right. So the evidence definitely doesn't support considering doing prophylactic prostatectomy. Though, there are definitely advantages to minimally invasive surgery. You're still out of hospital quite quickly, low blood loss, things like that. The risks still are there for any surgical procedure or any treatment option, whether it's surgical or radiation or whatever direction you choose. So the benefit that we get in prophylactic mastectomy definitely hasn't been nowhere near there for consideration for prophylactic prostatectomy. I still think if it is that you do have an abnormal gene or significant family history, perhaps just earlier surveillance and very strict surveillance is the answer there. And what we do is at earliest detection, you're armed with more information and then you go ahead with treatment at that point, as opposed to prophylactic prostatectomy, mainly because of the significant potential complications that you can get from these procedures.
Okay.
Okay, thank you, Dr. Reed. And this concludes our first session for Prostate Cancer Awareness Symposium. We thank all the presenters. Well done. And just reminding that this effort was made especially by Jamaica Cancer Society, the Guardian Group Foundation, and the Jamaica Urological Association. We will give a short break, literally 2 minutes, to stretch, use the bathroom, and then we will resume our second session, and I will hand over being moderator to my colleague, Dr. Roy McGregor, who will share the second session in 2 minutes. Thank you.
Hi, Earl. Afternoon.
you.
hello everyone. We're going to be recommencing shortly. There's going to be a quick 10-minute talk from a representative from the Guardian Life. This is Nadine Pottinger, who's sales advisor for Guardian Life, and she will be doing a 10-minute presentation shortly. So if you give us another few minutes until the first speaker is ready. Thanks. Come on now. Okay, folks, I've been told that our first speaker is ready. This, just to remind you, this is Nadine Pottinger, who's the sales advisor for the Guardian Life, and she will do a 10-minute presentation. Nadine? Well, we seem to be having some technical hitches at the moment. I could tell a story, I guess. I hope everyone is being well, being safe with COVID. It's funny times.
Or could we move to Dr. Greaves and bring on Nadine?
Yep, that's a good idea. Dr. Greaves, are you able to start your presentation?
Unmute, Dr. Greaves. Unmute.
Yeah. Can you hear me?
Yes, we can. So Dr. Venslow Greaves, he's radiation oncologist. He works at the Radiation Oncology Center of Jamaica. He got his undergraduate MBBS at University of West Indies and possesses a DM in Family and Emergency Medicine, a DMRT and FFRRCS Ireland. He also enjoys cricket and organ music and gardening. So without further ado, Dr. Greaves, over to you.
Thank you. Can I share my screen?
Yes, go ahead.
I see my screen. Oh.
Let's share screen.
Press share, but I don't see it. I want to thank.
There's a, Dr. Greaves, there's a
hit unmute.
Slideshow mode or viewing option at the bottom.
Don't further, Dr. Green.
Go ahead. Hold on. Hi, morning or good afternoon. I want to thank the organizers, the Jamaica Cancer Society, and their co-organizers, the Jamaica Urological Society, for inviting me to talk on radiation in the treatment of prostate cancer. I have no disclosures, and a brief outline is brief introduction, indications for radiation, prostate brachytherapy, external beam radiotherapy, a little bit about proton beam therapy, and my conclusion. The radiation oncology is really managed by a team. It's a team effort consisting of radiation oncologists or clinical oncologists in the UK, a medical physicist, a radiation therapist, a dosimetrist, and radiation biologist, and very large research centers. And I want to hail the team, my team that I work with at the Radiation Oncology Center of Jamaica. Wish them well, hope they're looking in. The electromagnetic spectrum is what we deal with, right? The electromagnetic spectrum is made up of non-ionizing radiation at one end of the spectrum, consisting of radio waves and microwaves. And then we get the visible end of part of the spectrum, and then we go into the area that we really were in, which is X-rays and gamma rays, which consist of very high frequency, low, very short wavelength type of radiation, which is damaging particularly to human cells, especially in the nucleus. There are many facets about radiation oncology. All tissues are made up of cells, and these cells are made up of protons and neutrons in the nucleus, and the nucleus is surrounded by orbits which contain electrons. Each of these entities have been harvested and can be used as electromagnetic radiation, ionizing radiation, and can be damaging particularly to human cells, especially the nucleus. And what we are more interested in the mechanism of action is that the radiation can damage the DNA, right? And it does this via a direct or indirect route. And it does this in some instances through free radicals, through an intermediary free radicals. And the next slide will show some of this, where ionizing radiation will react on substance in tissues, which is very commonly found in tissues such as water, to produce the high oxygen species. It can produce the hydroxyl free radical, and it can do this through what we know as the oxidative stress or reductive stress. And in the reductive stress, it can also produce hydrogen free radicals, and all of these can cause damage to lipids, damage to DNA, and damage to proteins and biomolecules in the actual cell itself. Now, radiotherapy in prostate cancer can be given as the primary treatment, and we can do this in association with brachytherapy. And brachytherapy is we utilize isotopes, radioactive isotopes such as iodine-125 and palladium, or high dose rate ones like iridium. And radiation can also be used in the post-prostatectomy setting, in settings where we know that there's a high incidence of recurrence. just to highlight this slide, that we try to concentrate on men and men who have at least 10 years survival, right? If you feel that you have sufficient comorbidities that you're going to die within 10 years, the early stages of prostate cancer, we tend just to watchful waiting. The NCCN guidelines, which we are guided by, if the most recent guidelines, 2020, it hasn't changed from 2019, which is highlighted here, states that photon and proton beam external beam radiation are both effective at achieving highly conformal radiotherapy with acceptable and similar biochemical control and long-term side effect profiles. And there are indications which are outlined for the use of radiation in the post-prostatectomy setting as well. Prostate brachytherapy may be used in the early form of prostate cancer, what we call the low risk category, or the favorable intermediate risk prostate cancer category. And we utilize iodine-125, right, which is inserted, which comes in the form of pellets, about the size of a rice grain. And these are inserted, we insert between 60 to 110 Cs into the substance of the prostate, right? We have had this capability in Jamaica since 2004. We have treated to date over 100 men, and it seems to work very well. We have not done the analysis of our studies yet, but there are other isotopes that can be used, such as cesium-137 and gold and cobalt-60 and iridium-192 have also been used and is currently in use. I think the capability for using high dose rate iridium for prostate seed implant, for prostate implantation, for prostate brachytherapy does not yet exist in Jamaica, but we have the capability for using iodine-125, and this is being used still. What forms an ideal implant? We try to make sure that we get a D90, and this is all technical, of more than 140 gray. Won't spend much time, but this is what we will see after the implant itself. We'll see we see all of these are the I-125 seeds that are in situ in the prostate gland. High dose rate will utilize only one source, like iridium-192. The source is kept in a safe, and we put in the needles and insert needles into the prostate, and this single source will enter each of these needles in turn. It's programmed to enter each of these needles and will give you a dose. It can be given twice. This treatment can be given 2 or 3 times, morning, evening, but they have programming in such a way now that only one treatment need to be given, and then these needles can be removed. And a lot of studies have shown the efficacy of this treatment. Right, I take you to the Sylvester one, which used in low risk and intermediate risk. There's 88% freedom from PSA recurrence rate. Long ago, Merritt in the British Journal, in the Urology Journal 2004 said that for low risk prostate cancers in appropriate patients, cancer control rates comparable to radical prostatectomy of over 90% can be achieved. And these are the categories that we will use prostate brachytherapy for. The low to intermediate risk. We can also use external beam radiation as well. And for high risk, for the high risk category, we have to use a combination of external beam radiation and brachytherapy. I will skip the randomized study because there's no real randomized study that compare the use of radiation with prostatectomy in prostate cancer. This is a retrospective study, and it was reported in 2004. And it showed that when we compare radical prostatectomy to external beam radiation for similar set of patients, remember it's a retrospective study, there was a 72% to 70% 5-year survival, freedom from PSA recurrence, p-value of 0.01, which is significant. The aim of external beam radiation is to deliver a precisely measured dose of irradiation to a defined tumor volume with minimal damage as possible to surrounding healthy tissue, resulting in eradication of the tumor, a high quality of life, and prolongation of survival. And there are multiplicity of studies that have shown since 1995 that when we hike the dose to the prostate, we can achieve better survival than what we used to have. Now, this is to highlight two things that in 2019, these were the guidelines for external beam radiation. It lists a number of treatments, and the 2020 guidelines is completely different. It now have moderate hypofractionation that is given radiation and high dose fractions over a shorter period of time as the treatment that is preferred. And formerly, the treatment that was preferred is now considered as conventional radiation. Now there's a subset here called ultra hypofractionation, which is not yet completely acceptable, but it's coming into fore. Now these are the type of techniques. We are coming from the 2D era, and we are going into the IMRT era. We have gone into the IMRT era, and we are going right down into protons. Intensity modulated radiation is the use of, we utilize advanced treatment planning optimization algorithms that are able to create the dose, right? A dose variation across the radiation field, right? And dose volume constraints for tumors and the surrounding organs have already been decided on. And this is what we do really. We tell the computer what dose we want to give to the target, to the tumor, and how much dose we are prepared to offset to the organs at risk, such as the rectum, the bladder, and the bowel and femoral heads. And we can achieve these objectives because inbuilt in the gantry head of the machine is something we call multi-leaf collimators. Now, these are shields, multiple shields that have its own motor, that are motorized, and we can create a dose variation across the treatment field of each beam. And the reason for this is outlined right here. We want to make sure that the rectum, we are treating the prostate here. We want to make sure that the rectum get as small a dose as is possible. Now these are the radiation fields. You'll note here that this is the intensity of the beam. If the beam is not seeing the rectum, the intensity of the beam is very high. If it is seen in the rectum, the intensity of the beam is very low. And this carries on for each field. So that if we look across a cross section of the field, we will find this, the normal tissues here are outlined in white, and the tumor is outlined in gray. Wherever the beam is seeing tumor will be high intensity. Wherever it's seeing organ at risk, such as the rectum, it's low intensity. So in this way, we are able to achieve a very conformal treatment field to the prostate. Now we have what happened in the initial stages is that it took some time if you're doing a treatment, for the fields to move to an angle, move to a different angle and change the field. It took some time. So we cannot program the computer now to change the shape and change the intensity of the field while it is rotating around the patient. This is called intensity modulated arc treatment. And this is a video that outlines what we are trying to achieve here. This is a state-of-the-art true beam machine located at the Radiation Oncology Center. If we look right here, we can see this is the prostate that we are treating, and the field is changing. This is intensity. This is volumetric modulated arc treatment. The field is changing as it is rotating around the patient. And advanced to this is a machine called the tomography machine, which looks like a CT machine, and it has a miniature linear accelerator rotated in the gantry, and it treats in slices as it rotates. It images the field and it rotates and treats. Stereotactic beam radiation has come into fore. This is the use of highly focal radiation beam, right? We have to be very precise at identifying where the prostate is, where the rectum is. And it has been shown that once we can focus that beam accurately and precisely, we can achieve 5-year biochemical relapse-free survival rates similar to external beam radiation treatment. This is a cyberknife that can execute all the treatments that are required in a stereotactic type of radiation treatment. Here is a linear accelerator is suspended on a multi-jointed machine, right? And it allows this linear accelerator to angle the beam from any direction, any angle. And we can treat both tumors in the brain, tumors in the body, and the prostate treatment very accurately and precisely. We come into the era of particulate radiation treatment, hadron therapy. And we started first using neutrons. Now we can use protons and carbon ions. If you look in the lower diagram, you see that, and we can compare the size of the carbon ion to protons. Now, for us to use protons or carbon ions, they have to be accelerated. We usually accelerate the protons in a cyclotron, removing the electrons, and we harvest the protons. The carbon ions are accelerated in a synchrotron, and it is harvested. And these accelerated ions can be used to treat tumors. And they have come into form, have been found to be very effective in tumors close to the heart, pancreatic tumors, inoperable brain, skull, and retroorbital tumors. And this is the beauty of this beam, right? The beam comes in at a very low dose, and most of the beam is deposited where the tumor is located. If we compare this to a photon beam, like an X-ray beam, where the beam comes in, hits the skin at a very high dose, as you get deeper into the tissues, there's a fall off of dose. So we have to use multiple doses to achieve the same thing that the proton can achieve. Just to show you, this is a tumor that is being treated in the chest. This is a photon or X-ray beam. There's a dose behind the tumor. In the proton, in the case of the proton, the beam ends where the tumor is located. And this is a comparison of a proton treatment using what we call a color wash. The red indicates the more radiation at the higher dose. So we can see that the green is low, it enters the skin. Only 2 beams are required, enters the skin at a very low dose, and we can achieve a very high dose where the prostate is. While in an IMRT treatment, we have to use multiple doses. And this multiple dose gives rise to what we call a high integral dose to the body. They have done studies to find out whether this is significant in terms of development of second cancers, second primary cancer development. And the studies are conflicting, with some studies showing yes, and some studies showing no. Proton controversies, there's a rush on to develop proton centers. Many of the large centers in the United States have their own proton centers now. The cost is pretty high, but there's a susceptibility to prostate motion. Just to remind you of the side effects of radiation, and this is a grid that allows you, if you have diagnosed with prostate cancer and you have your profile, you can decide which of these routes you want to take. So in conclusion, highly conformal radiotherapy techniques should be used to treat localized prostate cancer today. Photon and proton external beam radiation treatment are both effective at achieving highly conformal radiotherapy with acceptable and similar biochemical control and side effect profiles. Prostate brachytherapy is an effective modality in low and favorable intermediate risk prostate cancer. Stereotactic body radiotherapy is acceptable in practices having the appropriate technology, physics, and clinical expertise. And high quality radiation treatment now exists in Jamaica in both the public as well as the private sector for the treatment of prostate cancer. Thank you.
Right. Thank you very much, Dr. Greaves. Very informative talk. Just going to put it out to the floor. Do we take questions now, or we wait to the end? Are there any questions? Any questions at all? Simply unmute and okay. So thank you very much, Dr. Greaves, and thank you for your ongoing support for the Cancer Society. Our next speaker is Nadine Pottinger, Sales Advisor for Guardian Life. And I'm being told that to help us with time, she's going to cut her talk down to 5 minutes. So Nadine Pottinger, thank you very much for coming, and welcome.
Okay, good morning or good afternoon rather, and thank you. The Chairman, Jamaica Cancer Society, Mr. Earl Jarrett, members of the Jamaica Cancer Society and the Jamaica Urological Society, doctors, nurses, medical students, and other guests, good afternoon and a warm greeting from Guardian Life Limited. As mentioned, I am Nadine Pottinger, Senior Insurance Advisor. In 2018, the Guardian Group Foundation signed a memorandum of understanding with the Jamaica Cancer Society to increase public education and provide free screening for prostate cancer for our Jamaican men during the month of September, which is observed internationally as Prostate Cancer Awareness Month. In 2019, under the MOU, the foundation contributed a total of $3 million to offset the cost of a major public education and free island-wide testing. As a result of the COVID-19 pandemic, however, face-to-face activities have been suspended and have given way to remote activities such as webinar, symposium for medical doctors and other medical practitioners. We have also participated in several media interviews to continue our drive to educate the public. We have also increased awareness through infographics on our social media pages. As one of the leading providers of health and life insurance in Jamaica, Guardian Life Limited, through the Guardian Group Foundation, continues to support the promotion of good health through initiatives such as these. Ultimately, the company believes that with public education and proactive action, we can help to reduce and prevent the incidence of prostate cancer among our men. Guardian Life's mission is to lead the world in creating financial freedom for you in good times and in bad through positive interactions powered by technology. Life insurance is really about income protection. And there are just 4 reasons why income is important. 1, we may live too long and outlive our income. We may die too soon and not have provided enough for our family, for our children. Disability is another reason why you may lose your income. And of course, critical illness. At Guardian Life, we have developed a suite of financial solutions and services to help you solve these problems. And I'll just mention 2 of our major product solutions. The Guardian Ultimate Provider is a critical illness plan that provides income in the event of a major medical emergency, such as for the treatment of prostate cancer. The product covers 23 medical emergencies, along with an embedded savings element and life protection. With adequate protection and income for you and your patients, treatment of an emergency will be made much, much easier. As mentioned by Dr. McGregor, the cost can be significant, but once you're well covered, it should make life much easier. 2, our recently launched Guardian Extendable Term Series provides income for specific periods of time in specific amounts. It creates an immediate estate, as well as it is also the most competitively priced solution for mortgage indemnity and business protection, not only commercial business protection, medical business protection. Ladies and gentlemen, on behalf of Guardian Life, I wish you a continued and successful symposium and Prostate Cancer Awareness Month 2020. That is my short presentation, and I thank you.
Thank you very much, Nadine. So we're going to move on. We're doing well for time. And the next speaker is Dr. Belinda Morrison-Blidgen. And her talk is going to be on the medical management of prostate cancer. Dr. Morrison-Blidgen is a consultant and senior associate lecturer at University of the West Indies. She's very, very involved in research and does a lot of good work there. She's well known in the urology community and has helped the Cancer Society on numerous drives and so forth. So without further ado, I'd like to welcome Dr. Belinda Morrison-Blidgen.
Good afternoon, everyone. Thank you again to the Jamaica Cancer Society for facilitating my presentation this morning. And thanks to all the previous presenters. Thanks to you, Roy, for the introduction. And this morning, I'll be speaking briefly about the medical management of prostate cancer. And I'll just take the liberty to speak a little bit about our challenges that we have locally and our options as we move into a new phase where we have a lot more that we have gained in terms of research and newer agents and where we are in terms of Jamaica. There are no disclosures for me this morning, and my main objectives would be briefly to describe the epidemiology of prostate cancer in Jamaica, speaking specifically about some features that we see in Jamaica as it relates to data from the University of the West Indies. I'll speak broadly about androgen deprivation therapy, and then the place that chemotherapy has to play, as well as androgen directed therapy, bearing in mind that there is a further presentation later on by Dr. Brown on castrate-resistant prostate cancer. So we've heard this, I think, several times during the morning, but just to emphasize, because it has bearing on what I'm going to speak about, which is the incidence of prostate cancer, that it is quite high in our population. When we look at data from the Jamaica Cancer Registry housed at the University Hospital, we find that the peak age of occurrence of prostate cancer is in men greater than 75 years of age. And it's the highest incidence in all our cancers in Jamaica. So we are generally diagnosing the cancer in much, much older men. It also is the highest mortality of all cancers in Jamaica, 53.9 per 100,000, which is a very, very high rate when we compare to many other locations in the world, especially other nations in the Caribbean. So the burden is great, and it seems to be a burden borne mostly by elderly men that we diagnose. If we look at data from the University of the West Indies between 2005 and 2017, when we looked at a cohort of men that had been biopsied, we found that our positivity rate was quite high. It was 52%. In most series, you'll find a positivity rate of biopsies of about 30% or so. That being said, remember, this is not necessarily a screened population, but a population that is picked up really just by case finding. Our median age from this cohort was 69 years. So again, an elderly group of men, median PSA of 24. But what I wanted to highlight that most of the cancers that were being diagnosed were significant cancers. And these would say as Gleason 7 and above, as well as significant clinical disease. We further looked at a small cohort of patients from this group, 297 of, well, over 300 of them, 313 of them. And we looked at what happened to them from the time of diagnosis to the time of either death or a censored time. And we found again that most were older men. So 80% were over 60 with a mean age of 68 years. The PSA had a wide range between 2.3 and almost 17,000. So we had a mean of 367. Most had a high clinical stage, most had a high Gleason score, and most were metastatic. So this was a cohort of patients that we followed up. The relevance of this is just looking at the burden of the disease in our population, the type of disease that we see, at least at the University Hospital, and perhaps the need for androgen deprivation therapy. So we look at who are going to be the eligible or the candidates for this disease, are older men with much, much higher risk disease. And if we combine that with data that has been previously published from the Department of Pathology at the University Hospital, we find that most cases of prostate cancer currently diagnosed in Jamaica are advanced or metastatic at the time of presentation, and most are high risk. In the US, this is quite different. I mean, I know that the figures may have changed since there's been changing in terms of screening guidelines. However, for a long time, most cases that were diagnosed were localized, with advanced disease only accounting for 4 to 5% of cases, whereas we are seeing perhaps advanced disease in 2/3 of our men that are diagnosed. How does that relate to the androgen deprivation therapy? Well, it relates to the treatment that is chosen. So androgen deprivation therapy has indications for use in patients who have locally advanced or metastatic prostate cancer, or maybe in the elderly male who is unfit for surgery or radiation or doesn't choose to have such invasive treatment. It may be used as an adjunct in patients who have external beam radiation for a period of time, and also commonly used in persons who have had biochemical recurrence after treatment for localized disease. So it all boils down to the androgen receptor, and this is really where its effectiveness is. The androgen receptor is that final point that results in the coding of genes, that results in transcription of proteins that cause a long-term effect and sequelae for prostate cancer. Remember, testosterone is made primarily in the testes, but also a small amount in the adrenal gland, and its release is regulated from central areas, the hypothalamus and the pituitary. The hormone, luteinizing hormone, releasing hormone is released from the hypothalamus in a pulsatile fashion. And the net result is that there is release of testosterone, which is converted to dihydrotestosterone, which modulates its effects on cells, one of which are in the prostate. And so any mechanism of androgen deprivation therapy is affecting that entire cycle. And there's obviously feedback inhibition, as we are well aware. This all started off with the work of Huggins and Hodges in 1941. And this is a reprint of their paper. It was actually reprinted by the Journal of Urology a few years ago. But essentially, the report was that of a case series, and a case series of 8 patients with metastatic prostate cancer as seen on X-rays. And at the time, they didn't have PSA, so what they had was acid phosphatase. And they found that in men who had metastatic prostate cancer, their acid phosphatase levels were significantly elevated. And also they had an increased alkaline phosphatase level when they had bony metastases. In all patients, they were subjected to bilateral castration. And in 5 of these, they chose to either administer stilbestrol or estradiol, which are estrogen compounds. The result is that there was a reduction in acid phosphatase in all of these men and alkaline phosphatase eventually. And clinically, there was improvement. And also radiologically, there was improvement. So their conclusion was that prostate cancer was influenced by androgens. In fact, in this same study, it was a bit of a clunky study in terms of how it was done. So they had these 8 patients, but they also had an animal model where they administered the drugs, and they also had a model where they gave patients, animals, testosterone, and found that there was an elevation in acid phosphatase as well as alkaline phosphatase. So they were able to conclude that this cancer was influenced by androgens, where androgens caused, suppressing androgens, either by castration, chemically or surgically, they were able to control disease. And a lot of work has gone on since then and built on the work of Huggins and Hodges. What we do know is that androgen deprivation therapy is not curative. However, it does slow the disease progression. You will see in terms of biochemical response that there's a reduction in PSA. It definitely reduces the disease morbidity and improves quality of life. So for patients with metastatic disease that are having pain, it improves pain, and you see radiologically changes in the size of their metastases. And it improves survival. There is some modest survival that occurs, survival improvement, as well as in patients who have administration of this with radiotherapy. The challenge with these patients, however, is that their response is short-lived, anywhere between 24 to 36 months. Some articles say 18 to 30 months. And then they go into that phase of castrate-resistant prostate cancer. This is despite having low testosterone levels. And then now there is a challenge. So the desire would always be to have a longer period of time where there is response to these hormones. So what are the agents that are generally available and which agents are available in Jamaica? So androgen deprivation therapy in the current sense is considered any agent that's either an LHRH agonist, an LHRH antagonist, or surgical castration. You will find that most literature does not include anti-androgens in the group purely of ADT for treatment. It is a type of ADT, but in terms of what is recommended for treatment, which I'll discuss later, it's your LHRH agonist, antagonist, and surgical castration. What do we have available here in Jamaica? Well, we do have a few choices. For LHRH agonists, we have goserelin and leuprolide. And for LHRH antagonists, we have degarelix. And of course, there are other agents, the anti-androgens, which I mentioned, quite a few in the form of bicalutamide, flutamide, and cyproterone acetate. The National Health Fund has contributed significantly to affordability of these drugs. I certainly remember as a resident, we did not prescribe these drugs very often because the patients definitely could not afford them. However, in 2004, I believe the National Health Fund added a number of drugs for the treatment of prostate cancer, and it significantly changed the affordability of these agents. Currently, the agents on the list are the Zoladex, Lectrum, degarelix, bicalutamide in various forms, flutamide, cyproterone acetate, estrogens, and even now chemotherapeutic agents are available. So if we look at an earlier study done some 13 years ago, when we looked at the introduction of the subsidy for drugs for prostate cancer, my apologies, was in 2005. You see that before that time period, the most common way of treating prostate cancer for advanced disease, was surgical therapy with bilateral castration. However, after the introduction of the subsidy, where the drugs became much more available, we found that it was medical castration. I'm sure if we did that study now, we'll find that the figures are even more, the difference is even greater now, where much more persons are being offered medical therapy versus surgical therapy. So we use these agents a lot, and they generally are given continuously in most cases. And we spoke about the benefits that they have: modest survival improvement. It improves your quality of life, certainly improves your PSA. So just from looks, it's nice to see a patient come in and having a PSA that is low, and we feel good and the patients feel good. But these are drugs that the patients are given for the rest of their life, however long that may be. And so we must be cognizant of all the adverse effects and what the implications are. And certainly we're talking a lot more about these in the latter years. Patients may complain of fatigue. There are sexual side effects: loss of libido, erectile dysfunction, ejaculatory dysfunction. They may have hot flashes, which can be quite unbearable, at intense sudden heat in the face and the upper chest, with sweating. There are the cardiometabolic symptoms, which are probably the most vexing ones. So there is arterial stiffness, hyperlipidemia, insulin resistance, systolic hypertension, all components that can give rise to the metabolic syndrome. And this increases cardiovascular morbidity and mortality. And it's one of the major causes of death in patients really on these agents. So we should not take their use lightly or trivially. But how can we ameliorate these adverse effects? Well, there's an option of giving the drugs intermittently. So giving the drug in cycles with breaks. Once the patient gets the drug for a period of time, whether it's 9 or 10 months, and they do have a good PSA nadir or plateau, then you can opt to give them a break while continuing to monitor their PSA and reintroduce the drug at a later time. And certainly less exposure to the drug means less side effects while monitoring them. Bone mineral density reduction is also a major adverse effect that these patients have. It's something that I don't think we do a good job of monitoring, which we really should do at baseline once they are diagnosed and also during therapy. We should encourage the patients to do resistance exercises to maintain bone mass. And we should be aware of the drugs that can be used to help improve bone mineral density, because once there is reduction in bone mineral density, these patients are at a greater risk for fractures, and patients who are at a greater risk for fractures are also at a greater risk for mortality, and this has been proven. The hot flashes can be unbearable in a number of men, especially in our population. There are things that we can recommend, antidepressants, or behavioral modification like exercising, deep breathing, and relaxation. Some men opt not to take new tablets to deal with the side effect of another, but we should also let them know that it is an option. We looked at bone mineral density in Jamaican men on ADT. We were well aware that when we we did this study that many men were not routinely having their bone mineral density measured, let alone with the ideal measurement stick, which was the DEXA scan. And so for our study, we actually used a calcaneal ultrasound, which had been used in a previous study by Guinea when they were looking at bone mineral density loss in postmenopausal women. At the beginning of the study, we actually thought that our men had a higher bone mineral density than those quoted mainly from Caucasian populations, because we thought that we did not see many men with skeletal related events. And that's why it's so important to do studies, because what we did find was that the bone mineral density actually was lower in our men, and it was comparable to any other study. So the men started off with a baseline high bone mineral density, but with treatment, usually within 6 months or so, they had a reduction in their bone mineral density, which is in keeping with a lot of other studies. So the changes are quite quick. As early as 6 months of treatment, bone mineral density reduces. We did look at fractures in men who were on hormonal therapy for prostate cancer. There were a few limitations with that paper when published, but essentially we did not find as many fractures, but we were well aware that fractures could have presented in peripheral institutions. So it seems as if we do get the bony changes, but not necessarily as many fractures as other places may see. So these are all things that we have to bear in mind as we treat these men. And I know that family physicians are on the call on the presentation, and we co-manage these patients. And sometimes I do get calls about some of the things that we are doing. We have to mention to our patients why we're doing it and keep in touch with our family physicians as we write back letters to them to say why we are doing these things, so that they can be as much involved in the management of the patient as possible, particularly when it relates to the metabolic syndrome and the adverse effects of ADT, because this is where we need our family physicians to be involved in terms of optimal blood pressure control, optimal glucose control, cholesterol levels, and screening, if you will, for these adverse effects. Now, something that perhaps maybe not done as much as before, but still I see occasionally is patients being offered androgen monotherapy, that is just giving something like bicalutamide or flutamide alone. Bicalutamide alone has been proven in a study many years ago to have good PSA response and biochemical response. However, the current thinking of the AUA based on their guidelines is that they should not be offered as monotherapy. So that is probably why when you see a lot of articles on ADT, they do not mention anti-androgen monotherapy, because really the options that you're giving the patients are the LHRH analogs, antagonists, or surgical castration. What about maximum androgen blockade? You see a patient for the very first time, they have metastatic prostate cancer, they have a PSA of 1,000, and you feel you just need to start off with maximum androgen blockade. So you're blocking not only your testosterone from your testes, but your adrenal androgens, and you continue it for the life of the patient. It's something that is done very frequently, and there is controversy if there is actually a survival advantage in doing this. What the current guidelines from the AUA suggest is that they should not be given long-term unless it is just in the beginning to block the testosterone flare. We know there's the advantage of the LHRH antagonists in not needing to administer an anti-androgen for blocking testosterone flare. But certainly you need to give that for a person who is given an LHRH, for patients who have a LHRH antagonist, they don't need an anti-androgen to block the flare. But the patient who gets an LHRH agonist does need that agent. But pretty much the AUA is not in vogue really right now with maximum androgen blockade. And I mention it because I know it's something that we probably still do quite a bit of. So what about other agents? If we use these drugs so frequently and they have a half-life, if you will, of 2 to 3 years before the patient becomes castrate resistant, are there other agents that we can give to these patients maybe before they even become castrate resistant? And the answer is yes. So chemotherapy can be given to patients who are metastatic hormone sensitive. That is at the time of diagnosis, before they're even given even hormonal agents, you can try chemotherapy there. So the early studies were the use of chemotherapy for those who had castrate-resistant prostate cancer. So a rise in the PSA despite a castrate level despite having adequate ADT. With the success in that group, they figured, let us try it in patients who had hormone-sensitive prostate cancer. So at the time of diagnosis of prostate cancer, let's give these people chemotherapy. And it definitely worked out in that there was a survival advantage. In this landmark trial, what they found was that patients who had chemotherapy administered with androgen deprivation therapy at the onset, they had a 13-month longer survival as opposed to if they were given hormonal therapy alone. Another study, which was a little bit of a bigger study, where they looked at docetaxel, which was a chemotherapeutic agent, zoledronic acid, the so-called Stampede trial, showed pretty much the same thing. Standard of care at that time was ADT, and they compared it to patients who had standard of care on zoledronic acid, standard of care on docetaxel, and standard of care zoledronic acid and docetaxel. And what they found in persons who had standard of care alone, the overall survival was 71 months. But if they got standard of care and docetaxel, their overall survival was 81 months, and this was statistically significant. So herein lies a recommendation that patients who are diagnosed with metastatic prostate cancer, which is hormone sensitive, ideally should have chemotherapy given at the outset for the purpose of improved survival. How often is this being done? How often is it being recommended? And how often are our patients accepting this option? That's another matter. Without studying, we don't know. But to be honest with you, in a clinical setting, we do find that many times when we mention the word chemotherapy to a lot of our patients, they're not very accepting of it. And so we end up having more of our patients being sent for chemotherapy when there's castrate resistant rather than when they are castrate sensitive. But there is a role really, and we should be sending more and more of our patients to our medical oncologists. What is new, or newer rather, are the acceptance of many more agents, which I would say they are from the androgen pathway directed therapy. So these agents include abiraterone acetate, enzalutamide, and apalutamide. And in the same way in which chemotherapy was first studied in a castrate-resistant patient, these agents were initially studied in the castrate-resistant patient and found that there was a survival advantage. And now they have been used in the hormonal naive patient, or the patients who are castrate sensitive. And in all of these landmark trials, these are randomized controlled trials, they have found a survival advantage for them. So abiraterone acetate, enzalutamide, apalutamide, all if given early in combination with ADT prolongs survival. What's a major limitation to these drugs? Cost. However, in patients where they are given, you definitely see a difference in their response. There are additional interventions, and some of this may actually intersect with what Dr. Brown will speak about later. But we recognize that the care of patients with prostate cancer is multimodality. Maybe not done as much as we ought to in our country, is that we really should have more frequent tumor board rounds and discussions of cases before decisions are made. And the tumor board rounds ideally should have the input of urologists, radiation oncologists, medical oncologists, radiologists, to look at patient cases and make decisions about the best model or the best option for care. And you know, at the University Hospital, we do have tumor board rounds, which we try and use. I would not say that we use it for all patients, but certainly for complex patients, we try and present patients. And it gives them the best option. A lot of these patients will have pain, whether they have metastatic disease at first or not, and we have to introduce analgesics for their medical management. Sometimes they may need radiation to specific areas to relieve pain. If they do present with advanced disease, they may need nephrostomy drainage for relief of obstruction. Nutritional support is important, psychotherapy, and palliative care. So I'll just summarize by saying that we are aware in Jamaica that we have a high incidence and mortality of prostate cancer. But because our population tends to have high risk disease and present mostly with advanced cancer, ADT is used widely. It does reduce the symptoms of prostate cancer, and there's a very good and significant biochemical response. However, these responses tend to be short-lived, and then castrate resistance may develop after 2 to 3 years. Treatment requires a multimodality approach, and newer agents are available which are able to improve survival in patients who are castrate sensitive. Thank you.
Okay, thank you very much, Dr. Morrison. There's one question here before I put it out to the floor. And it's from an anonymous attendee. It says, I recall seeing that there is a link between development of dementia in patients on GnRH analogs. Is it causal, or is it just that the older males would have developed dementia?
Oh, that's a very good point, very good question. And yes, it is one of the adverse effects that has been seen over the last few years. Also another reason to be very mindful of ADT and the side effects. So there are papers that have been linked to dementia and these agents.
Okay, thank you. Are there any questions from the floor?
Quick question. In the old days, it was felt that this drug, Stilbestrol, was cheap and it was used commonly in the treatment of prostate cancer. Where are we today?
Yeah. Hi, Mr. Jarrett, how are you? So, you know, you are right. I mean, that's what Huggins and Hodges used back in the 1940s. However, it was used quite commonly years after, and one of the major side effects was that of, other than the breast swelling that the men got, which they didn't like, increased cardiovascular mortality. That was definitely the main thing. And so it really became out of vogue, particularly if it was given orally. I think there were a few people who are looking into it as second-line hormonal therapy. Some years ago, you saw papers coming out of trying to give estrogens parenterally to try and circumvent these the cardiovascular mortality. But you know what? It just has fallen out of vogue. It got such a bad rep initially, and then so many other newer molecules came about that nobody really talks about it as much. So no, it's not available. It's not there. Well, you can't even get Stilbestrol, period. And what we were using for several years was Premarin for patients who were now second line, so they'd had castrate resistance. And really, we just don't offer that anymore because the studies are just not there to support it. And there's so much there to suggest that it's a bad agent.
Thank you. Thank you.
Thank you, Belinda. I have a question. What protocol, or when you do your intermittent androgen deprivation therapy, what sort of protocol do you use? Do you stop at, who do you include in that, and what sort of regime do you put them on?
Yeah, right. So, I mean, it's all variable. As you recognize, you don't have a standard from anywhere. I believe, I can't remember what university's protocol I used, but there was one I'd seen, which is what I pretty much use now. A patient, regardless of what their starting PSA is, I think most people say if you get a good nadir, some people use less than 1, depends on what it started off as, less than 4, less than 10. Get a good nadir after about 9 or 10 months. Then you can opt to give the patients a break. And then what is variable now is what PSA you assign as your trigger to restart. As you know, there are some institutions that use 4, but again, it depends on what your nadir was to begin with, and some people use 10. But it's a little hocus pocus, I must tell you.
I know. That's why I was asking for your.
But I look at what the PSA nadired at, and then I decide, okay, based on that, say they're nadired less than 1, then I may use 1 as a restarting figure. If it was less than 4, then I may use 4 to be the figure that I restarted. But I'm very well aware that there's no proper study that has really looked at this.
No. Okay, lovely.
What I found though is that the patients have not been worse off either because of it, because I continue to monitor them and do their PSAs 3 monthly anyway. So if there's a significant rise, we restart and I find that they're not worse off.
Yeah, that's my experience as well. Any other questions for Dr. Morrison? Okay, if not, Dr. Morrison, thank you very much for another fantastic presentation. So we're going to now move on to Dr. Gafour, Ray is a consultant urologist. He has a BSc in biology, MBBS, and DM urology. He's fellowship trained in minimal invasive surgery, oncology, and has an honorary appointment in renal transplantation. Ray Gafour is an accomplished minimal invasive surgeon dedicated to benign and malignant disease in urology with specialized expertise in urinary stones, uro-oncology, and renal transplantation. Presently, he's a consultant surgeon at Kingston Public Hospital and an associate lecturer at University of the West Indies. He graduated the University of the West Indies, Mona, where he attended medical school, further specialized in urology there and obtained his DM, a doctorate of medicine. He attended Masters University and the University of Toronto for elective training during his residency. Dr. Gafour then subspecialized with fellowship training in minimal invasive surgery, endourology, oncology, as well as received an honorary appointment in renal transplant surgery in Melbourne, Australia. Dr. Gafour is a member of the American Urology Association, Society Internationale de Urologie, European Association of Urology, and is secretary-elect of the Jamaica Urology Society. He's a very passionate educator and has presented on a wide variety of urological topics and promotes gold standard as well as state-of-the-art surgical approaches and principles. Without further ado, I'd like to introduce Dr. Gafour.
Good afternoon. Thank you for that, Dr. McGregor. Good afternoon, everyone. It is a beautiful afternoon in Kingston. I hope you're all enjoying the day. It's my distinct pleasure to talk about the role of surgery in prostate cancer. I'll limit myself to the role of radical prostatectomy and not any other surgeries, as we have a limited amount of time and a number of topics to discuss. As such, I have pointed out 4 topics, at least 4, that I'd like to touch on, since again, we've only got 20 minutes. One, I'll talk about the role of radical prostatectomy in the low and intermediate risk cancer. When I started residency, we were still doing prostatectomy for men with Gleason 6 disease and low risk disease. And by the time I'd finished training, we were hardly seeing those men being offered surgery. So certainly there's been a shift. And those men are hardly ever offered surgery anymore. They're usually encouraged to undertake active surveillance. But we'll still talk about, is there a role for some of these men with low risk disease? Secondly, I'd like to discuss the role of surgery in those with more advanced disease, T3 disease, and certainly they have the external beam radiotherapy has seen a large share of those men, and is there still a role for surgery in those men? Thirdly, is there any benefit to surgery in the oligometastatic patient, that's a patient with 5 or less mets on imaging? And finally, does a surgical approach make any difference comparing open and robotic prostatectomy? So if we look at the CAPTURE registry, which is a large database, we'll see that over the years, if you look at low risk disease on the left, there's been an almost exponential increase in active surveillance after 2005, right about the time that, or maybe just a little bit before the time that Lawrence Klotz and Soloway et al. And a number of other researchers published their data on the safety and benefit of active surveillance. And we became aware of the risk of over-treating men with low risk disease. So you'd see a concomitant decrease in the rate of surgery being offered. And at the same time, radical prostatectomy became more popular in men with higher grade disease, intermediate and higher risk disease. And even compared to radiotherapy in the last 5 to 10 years, surgeries become more, and we'll look later on where that might be. Third, radical prostatectomy is indeed an effective surgery to offer. If you look at the cancer-specific survival rates in long-term trials, or at least long-term databases, at 10, 15, and 25 years, surgery is associated with CCSs of 95, 85 to 90%, even 86% at 25 years, and that's Patrick Walsh's single surgeon retrospective experience being published there, along with excellent progression-free recurrence rates, progression-free rates and metastatic-free rates. But when you look at WILT, the first study there, the PIVOT trial, did surgery actually make a difference? We're not really sure, because they compared, if you look at all risk groups, there's only a 3% reduction in CCS if the patient offered surgery versus observation. It was not significant. But when you look at the guts of that study, and you sub-stratify according to risk factors, low risk was the only one that really tended towards a benefit for the observation arm. And if you look at intermediate to higher risk surgery, that tended towards a benefit for those patients who had surgery. So certainly we know there is a risk of overtreatment. There's only 1 in 100 patients with low risk disease will die of their cancer. And that's why a lot of them are being offered active surveillance. But what about those, would there be some men who would be good candidates with Gleason 6 disease for surgery? Certainly we'd be able to offer them excellent cure rates with the low recurrence, both biochemical and clinical. In addition, it hardly can be considered a radical surgery. It's more of a limited surgery, as we rarely would do lymph node disease in low risk cancer, thereby reducing the complication rates, especially by way of the incidence of lymphoceles. The follow-up would not be complicated or prolonged. There would be no intricate imaging, routine imaging, or rebiopsy rates, and you would not expect to have adjuvant therapy indicated. But again, the fear of overtreatment. So the first hint of whether this would be useful and in whom it would be useful comes from the Scandinavian prostate cancer group trial, where roughly 700 men were assigned randomly to surgery or watchful waiting. And they all had localized disease and life expectancy greater than 10 years. And primary endpoints were death from any cause, death from prostate cancer, and the risk of distant mets. The caveat is that this is in the pre-PSA era. And when you subselect men who were younger than 65 years of age, you see that for low risk disease, that is men with Gleason 6 and PSA less than 10, there was a significant benefit, almost 43% in terms of reduction of death from any cause, and a significant, almost 60% decrease in the risk of distant mets. And there was roughly a 40% decrease in death from prostate cancer, although that was not significant. It certainly was trending towards a benefit being seen. Then the PIVOT study came out, which is the American trial, and they likewise attempted to look at the benefit of prostatectomy. Could this be translated across the ocean in the PSA era? So again, 700 men being randomized with localized disease, and the primary endpoint was all-cause mortality. And unfortunately, there was no significant difference that was seen in terms of death from any cause or death from prostate cancer. There was very little separation of the Kaplan-Meier curves there. But once again, when you look into the guts of the study, you'll see that for intermediate and high-risk disease, there definitely is a trend towards surgery in both death from any cause and death from prostate cancer. And it is the low-risk disease that didn't really hold up its end of the bargain. Although certainly trending towards so in death from prostate cancer, but maybe not statistically significant. What's interesting from the study is that when you looked at the death from other causes, that rate was roughly 40%. 40% of patients died from other causes. And that's a little alarming, because when you compare it to other contemporary studies, that number is usually around 7 to 10%. So it may indicate that patients who were not the best candidate according to our current selection criteria. Patients with multiple comorbidities or may have been had less than 10-year life expectancies may have been included in the study, and that's why they may not be benefiting from surgery. So again, maybe it is that there are a certain selection of men who are less than 65 who have more than one risk factors and who've got good life expectancies and low comorbidities, who may live for quite a long time with disease, who may be better treated with upfront surgery. Switching gears to the patient with a high-risk disease, the rationale for offering these patients as patients with T3 or high PSAs above 20 is that the rationale for offering surgery is an attempt at cure. And certainly even if we don't cure them, those with locally advanced disease at least, we're able to alter the course of their disease. And Briganti et al. Published interesting data looking at the biochemical recurrence-free survival rates at 10 years of those patients who only had surgery. So they were monotherapy, monomodal therapy, and almost half of them had no biochemical recurrence at 10 years, and only a third of them needed adjuvant treatment, either for clinical recurrence or worsening biochemical recurrence. So radical prostatectomy is very effective as a monomodal therapy in a large number of patients with very aggressive high-risk disease. And if you were to substratify those patients who only had one risk factor, then the Kaplan-Meier curves separate even more there, and it's even more beneficial for these men. One of the reasons for that is that there's a significant amount of downstaging on the final pathology. So roughly in higher risk patients, roughly 44% of them on final pathology ended up having localized or T2 disease. And a lot of those patients would have been excluded on pre-op staging if you did not include higher risk patients as an inclusion criteria for surgical candidates. And Briganti showed that about 90% of patients with higher risk features were had cancer-specific mortalities. The overall rate at 10 years for high risk cancer is about 90%. And if you had a negative margin, that advantage was even greater. So the next set of curves that you see there, the top line is for negative margin or specimen confined disease. And the cancer-specific mortality was 98 versus 87% of men. And for biochemical recurrence, even further separation of the curves, there 65 versus 47%. So definitely a real advantage if, even though you preoperatively, you may have been classified as high risk, you turn out to be T2 disease. Again, roughly 50% of men would not have needed adjuvant therapy. At 3 years, about 63% of men did not need adjuvant radiotherapy or salvage radiotherapy, and 67% did not need adjuvant or salvage hormonal therapy, and they would have been spared significant side effects from those adjuvant therapies. The standard, when you compare radical prostatectomy as a monomodal therapy, the standard for radiation is that these men with high-risk disease would routinely, all of them would get, unless there's a distinct contraindication, would get 3 years of hormonal therapy. So again, we'd be sparing patients, roughly 50% of patients, the side effects of those. Is it as good as? Well, unfortunately, we don't have any good prospective data. What we have is some retrospective data, which is less than ideal, mostly because of significant selection biases. So patients with more aggressive diseases or older patients with more comorbidities may have been more siphoned off towards radiation arm or surgery arm. We just don't know what the details are. But the best data we have is in the form of randomized analyses. And Petrelli 2014 published 17 studies, one of which was randomized. And when you look at radical prostatectomy, there was a definite benefit that was significant for overall survival and cancer-specific mortality. And there was only one study that trended towards favoring the radiotherapy arm. Again, we're not sure what how good this data is, because with meta-analyses, if you have poor data in, you get poor data. The publication SPC, or Scandinavian 15 prospectively randomized trial in a few years that randomized men with T3 locally advanced disease to surgery or radiation plus ADT. What about the complication rate of surgery versus radiation? If you look at other than functional outcomes, so traditionally functional outcomes are erectile dysfunction and incontinence rates. If you look at other than those outcomes, there is a large population-based study that's retrospective of about 32,000 Canadian patients that looked at admission rates and secondary procedures, secondary cancers, and radiation had almost twice as high incidence, and that was significant. Again, prospective study will hopefully come in the way of the SPCG15 trial. But in all fairness, realistically, we know that surgery will be more aggressive for these patients who potentially have extracapsular disease, may have seminal vesicle invasion, positive margins. It is unlikely that you're going to be aggressive in trying to spare the neurovascular bundle. Surgeons will probably be more conservative and take the bundles, which, as we know, is responsible for potency and continence rates. So you'd expect those rates to be higher than those patients with low risk disease. Moving gears, changing gears again, let us look at a patient with oligometastatic disease. Is there a role for surgery? And by that, we mean patients with less than 6 METs on imaging. And the rationale for this is that the resection of primary cancer is standard in many other cancers, in many other oligometastatic cancers. And we accept that it is likely that this will be part of a multimodal approach. We know that it does avoid local complications such as hematuria, bladder outlet obstruction, acute retention, hydronephrosis from nodal obstruction of the ureters, pelvic pain, etc. And we're not sure why that might be. It's hypothesized that we're removing more aggressive disease and the site of potential further metastases. What's the evidence for this? Well, local treatment does provide palliative benefit to men who go on to later develop castrate resistance. One et al. 2013 compared men who had surgery in oligometastatic states compared to definitive radiation to those who had no treatment at all. And those who had surgery did better. And with that, it translates to better quality of life. And again, we know that there's success in other disease states like ovarian, colon, and renal cell cancers. So why not? Why not in prostate cancer? Well, these databases give us a little glimpse into what may be. The SEER database does show, is in favor of surgery in terms of cancer-specific mortality, but these are highly selected patients who are younger and fitter with a lower tumor burden. And this is retrospective data. Again, the Munich Cancer Registry, we see some separation of the curve to the right for the patients who have surgery. This was a large population-based study of more than 8,000 men with oligomets, and those who had surgery did better than those who did not, and even those who had radiation. There are some prospective randomized trials to come out that we would eagerly await. Studies by MD Anderson and the HORAD and sub-analyses of arms of the STAMPEDE trial comparing surgery to ADT, surgery to radiation plus ADT. And in these studies, most of them are trying to homogenize the data, so looking at patients with the same inclusion criteria. Finally, what approach to surgery should I recommend for my patient? Does it matter? Do any of them matter? And primarily, we're going to compare open to robotic assisted because that's where the majority of the literature is these days. We certainly know that robotic is becoming more and more common. Approximately 90% of surgeries are done robotically in the United States. Europe is probably lagging a bit with Germany at about 30%, but they're quickly catching up. The unfortunate data again is from population-based studies where there's significant underreporting of complications There's heterogeneity in the techniques and significant selection bias. So obesity may tend to have a patient put in one arm versus the other. Prostate size and morphology, certainly larger prostates tend to be reserved for open surgery, although that is changing. At the end of the day, no international guideline has stated a clear advantage of any one approach versus another when it comes to the major primary endpoints. If you look at the overall complication rates, and these are a thorough meta-analysis and systematic review of the literature. On the left, we're looking at open surgery versus robotic. And though not statistically significant, there is indeed a trend, a 25% greater chance or lesser chance that you have overall complications in a surgical arm. When you compare the laparoscopic experience to robotic, again, not statistically significant, but trending towards benefit in the robotic arm. The operative time, the left is comparing open to robotic surgery, and not significant again, but the benefit tends to be with open surgery. And on the right, laparoscopic versus robotic. And this was a significant difference in that robotic was quicker than laparoscopic. So when it comes to open versus lap, we have no head-to-head comparisons in this study. If you were to extrapolate the data, it would seem that open would be quicker than robotic, which tends to be faster than laparoscopic. Does this have any real implications for patient outcome? We don't know. Does a quicker surgery lead to better functional outcomes? We don't know. You know, we'd have to await prospective studies for that data. If you look at the potency rates, it was significant in favor of robotic when it comes to potency rates. Again, laparoscopic versus robotic, a trend towards robotic, but maybe not significant. There are a few randomized trials on which we can lean. Yaxley et al. Published a very good study with 326 men randomized to open surgery versus robotic. But at the end of the day, at 6 weeks of follow-up, they had almost exactly the same functional and oncological outcomes. And there was no superiority that was demonstrated using superiority testing techniques. The caveat here is that there were essentially two surgeons and patients were randomized to either arm. One surgeon did open, one surgeon did robotic. So are we actually just comparing surgeons or are we comparing techniques? At the end of the day, the authors had to admit that they would encourage patients to choose an experienced surgeon rather than a specific surgical approach. I particularly like this study. It may give you some kind of yardstick that, that underlines the experience is as important, if not more so, than the approach. At 5 years, biochemical recurrence rates significantly decreased in surgeons who had done more than 250 prostatectomies. And when you reached 1,000, you sort of plateaued out. And that was regardless of technique used, whether it was robotic, whether it was open, whether laparoscopic, didn't matter. The 250 seemed to be a magical number. And clearly there will be some variability where that's concerned. And it didn't matter the aggressiveness of the tumor, that was for all comers. And interestingly, that surgical experience did not translate. So if you are a high volume open surgeon and you convert it to laparoscopic, it did not translate to laparoscopic success immediately and vice versa. So it's interesting data. In conclusion, just to summarize those points, as 4 or more points that we touched on, surgery is an excellent treatment for prostate cancer and potentially expanding role for patients with low risk disease. Select patients, I should underline. There's a migration in terms of engaging more aggressive disease and taking on T3 disease. There certainly is at least an investigational interest in treating patients with oligometastatic disease. Surgical is mainly not significant as surgical experience. And moving forward, I think that this would be an interesting topic going forward, is the role of salvage lymphadenectomy. As we're developing better and better techniques at imaging patients with lymph node disease and at staging. So for example, the PSMA PET scan is particularly sensitive in lymph node disease. For the patient who's post-op and has a biochemical recurrence or clinical recurrence, and you do a PSMA PET and it shows limited or X number of lymph nodes in the pelvis, what is the role of salvage lymphadenectomy in addressing this, and does it have a benefit? Does it have a survival benefit? So I would certainly welcome those studies that are ongoing. I would eagerly await the publication of those results. I thank you for your time, and I do hope that this has stimulated some interest in the topic.
Thank you very much, Dr. Gafoor, for a very informative discussion or presentation. Are there any questions from the floor? Ray, I have a question for you. I thought you touched on oligometastatic disease and the role of radical prostatectomy in this setting. As far as I know, there's a large MRC trial looking at this. And the initial data seems to imply that there may well be a role. Have you had any experience with it yourself, or?
That's correct, Roy. There is a phase 3 large randomized study underway, and yeah, I think we're all awaiting the results. I personally have not been that aggressive in my personal experience. I have been tending towards treating these patients with radiation and systemic therapy, but if the data, and the data are the data, if the data shows that there is an advantage, then I would definitely not be adverse to changing my practice. Certainly you would think that extended lymph node dissection would have to be undertaken in these, and intuitively you'd have to think that there must be some cutoff in terms of the volume of nodal disease. I mean, if for example a patient had 25 positive nodes or 30 nodes, you'd have to think, well, maybe that's not quite what we're talking about. And likewise, if a patient had multiple distant mets, we're not really talking about distant mets. I'm assuming that what we're talking about is skeletal mets, a limited number of skeletal mets. But
it's an exciting area because I was speaking to Prof. Eden about it the other day, and the actual theory is that the primary cancer communicates to the metastatic lesion. So they think that the primary cancer actually sends out cells to populate metastatic lesions, and it's not just a case of the cell, the fertile soil and seed where the cancer deposits and then it grows. And so that's part of the reason why they think it may be more beneficial than they at first thought. But it'd be very interesting to see what the data shows,
I think you're right. And I think that there similarly is a lot of crosstalk between metastatic deposits. So it may not all just be coming from the primary. If you look at the tumor, the tumor factors like VEGF and so on, there has been some investigational evidence that there's crosstalk between metastatic,
metastatic lesions,
yeah. So it may not solve all patients' problems, but look, if you can help someone even delay, the onset of metastatic disease, of distant mets and local complications, then you're definitely winning the war.
Yeah. And I mean, I have quite a few patients now with T3 disease, with seminal vesicle involvement. There were a couple that where the MRI showed rectal involvement, but I consulted with Prof. Eden and sent the films, and he said, no, it's fine. And we went ahead and got a good result. And in fact, there's one patient who's a friend of mine who had Gleason 9 disease in 2 lymph nodes, and he's now 18 months post-surgery with a PSA of 0.1, not having required any adjuvant hormonal treatment or radiation. So it, you know, it'd be interesting to see, you know, how he fares going forward, but so far so good. But I do think, I suspect that we're going to find that even from a palliative point of view, you know, so that the patient doesn't have to have a catheter and bleeding and all these various other symptoms you get with locally advanced disease. I'm looking at this space because I suspect it may turn out that it will be beneficial to the patient, both from a survival and palliative point of view.
Yeah, absolutely, especially with all the adjunctive modalities of treatment having at our disposal. You know, it's not going to be a monomodal approach. And with the advent every year with newer and newer meds to help you, you have to think that the life expectancy of these patients is going to increase further than the 5-year castrate resistance that you would expect presently in these patients who have you know, post-op metastatic disease. You have to think that they're going to trend towards 10 years and maybe even 12, 15 years, who knows. If it was me, I probably would opt for that. That's my first.
I think I probably would as well. Thank you very much, Dr. Gafour, for another very comprehensive presentation with a lot of behind-the-scenes research into the subject. Okay, so we've now reached the final speaker, Marie Brown. Marie works at the University of the West Indies. She's a urology clinical fellow. She's got a BSc and MBBS, as well as her DM in urology. She enjoys traveling and family and life, etc. So without further ado, let's welcome Marie Brown.
Good afternoon, everyone. I am grateful to the Jamaica Cancer Society and to Jamaica Urological Society for asking me to talk today on castrate-resistant prostate cancer. Advanced prostate cancer patients are those who have exhausted all local therapeutic options, or they had initially presented with metastatic hormone-sensitive prostate cancer. For those patients who have exhausted local therapy, they usually manifest with biochemical recurrence, and then these patients go on to be either non-metastatic castrate-resistant or metastatic. And these patients benefit from androgen deprivation therapy using either LHRH antagonist or an agonist. And basically this is given as a primary systemic therapy for regional or advanced prostate cancer, and it can be given in combination with radiation as well. ADT is the gold standard for initial treatment in patients with metastatic disease. Before long though, most patients will eventually stop responding to this traditional form of hormonal therapy, and they will begin to experience an increase in PSA levels. And these patients are termed as castrate-resistant or castrate-recurrent prostate cancer. The problem with this stage is that the median survival is about 15 to 36 months, and this is also dependent on the burden of disease at the initial time of resistance. Castrate-resistant prostate cancer is defined by both the American Urological Association and European Association of Urology. And basically both say the same thing, where there's disease progression despite ADT and a castrate level of testosterone less than 50 nanograms per deciliter or less than 1.7 nanomoles per liter. And this is in combination with either biochemical progression or radiographic progression. Biochemical progression is the continuous rise in the serum PSA levels, and this is usually done at about weekly intervals with a minimal PSA value of 2. And anything that rises above that level with a continuous rise, that is considered to be biochemical progression. Also with radiographic progression, that is the presence of 2 or more bony lesions on a bone scan. And this can be confirmed with either an MRI or a CT scan if there's any ambiguity in this, or as well as if there's a soft tissue lesion present. Both the Europeans and the Americans basically say the same thing. The only difference is in the American Urological Association definition, they actually consider patients who have symptoms of progression as well as serum, castrate level testosterone. They are considered to be castrate resistant. This is not so for the Europeans. Castrate-resistant prostate cancer develops by various mechanisms, and these include the ability of the prostate cancer cells to utilize intracellular androgens via de novo synthesis that may be exogenously from the adrenal glands or from the tumor microenvironment. There's also increased androgen receptor expression on some of these cancer cells. The androgen receptor gene may undergo mutation, and this results in activation, in activation by other ligands other than androgens. There may be alterations as well in androgen receptor signaling, and this results in increased tumor growth. Lately, there has been a lot of study in the androgen receptor variant, ARV7, where this can become synthesized and result in activation even in the absence of ligands. And these are the various mechanisms that will result in castrate-resistant prostate cancer. In terms of management for these patients, as Dr. Morrison alluded to, this is a multidisciplinary team approach. It cannot be done by just any one set of physicians, and the team involves urologists, medical oncologists, radiation oncologists, genitourinary pathologists, genetic counselors, palliative care, and holistic specialists, as well as a primary care physician. The choice of treatment for these patients is primarily dependent on prior therapy that they had before becoming castrate resistant, also their performance status and life expectancy. Performance status for these patients basically looks at the individual's level of functioning and the impact that the disease has on the patient's activities of daily living. And there are 2 main tools that we use for evaluation of performance status, the ECOG score and Karnofsky scale. So prior to 2000, localized or metastatic hormone-sensitive prostate cancer, the only treatment available was ADT. And when they become metastatic castrate, then the only treatment available at the time was mitoxantrone and prednisone. Since this year, 2020, we've noticed an increase in addition of agents available to treat various forms of advanced prostate cancer, even up to the metastatic castrate-resistant patients who had gotten chemotherapy as well, and we'll go into all of these. Advanced prostate Castrate-resistant prostate cancer is an advanced form, and it usually portends to a poor survival for these patients. The sequencing of medication and outlining treatment is a bit difficult. And to assist with this, the American Urology Association basically stratifies patients according to their performance status, prior docetaxel use, and the presence of symptoms. And as a result of this, they have defined 6 index cases that we look at, and the treatment guidelines are basically dependent on the level of evidence. Some may not be level 1 evidence, but there are clinical principles and expert opinion that we use to guide us. And the first index patient is the asymptomatic, non-metastatic castrate-resistant prostate cancer patients. These are the ones who have a rising PSA without radiological evidence of metastatic disease, and they're largely, they have no symptoms of their PSA progression. For these patients, we can monitor them every 3 to 6 months with a PSA and conventional imaging with a CT scan or a bone scan at 6 to 12 monthly. These patients, however, are at a high risk of developing metastatic disease, and this is noted by a PSA doubling time of between 10 to 12 months. And when that happens, these patients should continue on their hormonal therapy. And in addition, with high level of evidence now from 3 large phase 3 trials, we've added enzalutamide, apalutamide, and darolutamide to the management of these patients. Prior to 2018, this was not the case. Enzalutamide got its approval after results of the PROSPER trial was published in 2018. And basically, they looked at over 1,400 patients who had non-metastatic castrate-resistant prostate cancer and a PSA doubling time of less than or equal to 10 months. And basically, patients were randomized in a 2-to-1 fashion to receive enzalutamide and ADT, or placebo and ADT. And they had found significant benefit in using enzalutamide and ADT in the median metastatic free survival. So the time to which patients develop metastases was significantly longer in the enzalutamide group compared to the placebo group, who was just on ADT alone, which was a prior standard of care. These patients also had a significant survival, metastatic free survival benefit, as well as the time to death as well. In the same trial, they found that patients also benefited from a longer time to PSA progression while on enzalutamide compared to placebo. And also the time, as you can see from this graph here, actually showed that the time to use of other antineoplastic agent was significantly longer for enzalutamide, with a significant number of months over placebo alone. So this received FDA approval, and so enzalutamide is now a part of the therapy for non-metastatic castrate-resistant prostate cancer. In terms of those patients who died in that trial, there were less patients in the enzalutamide ADT group compared to the placebo and ADT group. Up to June of this year, there has been no study looking at overall survival as a primary endpoint. All the studies looked at the metastatic free survival. And this study by Sternberg that was published in the New England Medical Journal in June of this year actually showed that there is a significant overall survival benefit in giving these patients enzalutamide over placebo. Apalutamide got its FDA approval from the Spartan trial, where they looked at over 1,200 patients as well who had non-metastatic castrate-resistant prostate cancer with a doubling time of less than 10 months. And they were randomized in a similar fashion. And what they found as well was that there was a significant longer time to meds for the apalutamide group in comparison to the placebo group. And also The time to PSA progression was significantly longer in the apalutamide group compared to placebo. In this study, they actually pointed out that the adverse events were greater in the apalutamide group versus placebo. Darolutamide, the newest agent added to the options for non-metastatic prostate cancer, was actually completed in 2019, and they too randomized patients to darolutamide and ADT, as well as placebo and ADT. And there was a significant difference in the metastatic free survival for patients on darolutamide compared to placebo. So these patients actually have more options now in 2020 compared to what they had prior to this time. Now we move on to metastatic castrate-resistant prostate cancer. And as we pointed out before, the options available now are much more. And in an AUA guideline statement, they actually give guidelines to help to manage these patients. And they suggest that in these patients, we should have a discussion. The aim is to have an informed discussion with these patients as to the prognosis and the treatment options available. And for these patients, they do require follow-up by either their urologists or primary care physicians, and they require baseline blood studies looking at their PSA level, testosterone levels, of course, to make sure that they're still in the castrate-resistant range, and also to review their metastatic imaging to look at the presence of bone, lymph node, or visceral metastases, because that will also depend. The treatment available will also be dependent on these. And also the disease-related symptoms and their performance status should be evaluated. In patients with metastatic castrate-resistant prostate cancer, they are now considering and looking keenly into offering germline and somatic tumor genetic testing in these patients, because a lot of these patients, well, studies are showing now that some of these patients, or a lot of them actually, have DNA repair deficiency mutation or microsatellite instability, and that will help to be to decide on prognostication for these patients, and also to counsel the family as it relates to their potential risk of developing cancers. AUA index patient 2 is the asymptomatic or minimally symptomatic metastatic castrate-resistant prostate cancer patient who had not had prior docetaxel chemotherapy. So if you recall from Dr. Morrison's presentation, for patients who present with hormone-sensitive prostate cancer, metastatic prostate cancer, these patients actually benefit from docetaxel or abiraterone therapy. And these patients, within another 2 to 3 years, may go on or will likely go on to develop castrate-resistant disease. So if these patients, the AU index 2 patient is the one who has not had prior docetaxel therapy. And the treatment options involve pain control, because these patients are symptomatic, abiraterone, sipuleucel T, and docetaxel are options for these patients. Abiraterone was studied in the QAA 302 study by Ryan et al. In 2013. And basically what they did, they randomized over 1,000 men into patients who will receive abiraterone acetate, 1,000 milligrams daily, along with prednisone, to counteract the effects of the side effects of abiraterone, as well as giving patients prednisone alone. This is in addition to ADT, of course. And what they found was that there was a significant overall survival advantage in the abiraterone and prednisone group versus a prednisone group alone. In fact, the overall survival was not reached in the abiraterone and prednisone group as it did for the overall survival. So this actually changed the management of metastatic castrate-resistant prostate cancer. And so this agent was added to the list of treatment availability. Sipuleucel T is the only immunotherapy available for castrate-resistant prostate cancer or any prostate cancer treatment in that at all. And basically this received FDA approval after its use in 512 men who were randomized to Sipuleucel T. And basically this is basically an office procedure where the patient, a blood sample is taken from the patient and this is sent to a lab where they would identify these antigen presenting cells. These are in a lab, they're bound to fusion proteins and then reinfused into the patient as these activated antigen presenting cells. And these go on to help the patient to have an immune response basically to the prostate cancer cells, and that will help to fight the cancer. They noticed that there was a 22% reduction in death in these patients. The problem with Sipuleucel T though is that the PSA basically plateaus with treatment, so there's no monitoring of PSA in these patients. Docetaxel use was also confirmed as well, and patients were randomized in the TAX327 trial to docetaxel 75 milligrams per meter square every 3 weeks versus 30 milligrams per meter square weekly, as well as mitoxantrone. And what they found was that the patients who had the 75 milligrams per meter square 3 weekly, these patients had a significantly better overall survival than those on mitoxantrone. And also the median survival in this group was significantly better. However, the toxicity was more in this group. But overall, there was a benefit in using docetaxel for these cancer patients. If docetaxel is not available or the patient is unable to do so, usually we would give a first generation anti-androgen like bicalutamide or flutamide. This, however, is no longer included in the AUA 2020 guidelines. Ketoconazole plus steroids, that is available, that is still on the guidelines, but it is only if patients are unable to take any of these agents or they're just not available. Observation is also an option since these patients are minimally symptomatic and they have not exhausted all their treatment. AUA index patient 3 is a symptomatic patient who has good performance status and no prior chemotherapy. And for these patients, the primary goal is for pain control, and the treatment options again are abiraterone and docetaxel. And we have the studies that I outlined before that actually support the use of these agents. Radium-223 was added for symptomatic bony metastases, but these patients, however, should not have visceral metastases. And radium-223 is actually an alpha-emitting radiopharmaceutical that is capable of causing breakage in the double-strand DNA of cancer cells. And while doing this, it actually minimizes exposure to the surrounding marrow. Its use in bony mets rely mainly on its similarity to calcium and its ability to bind this to these cancer cells in the bone. And it actually is short-lived and helps to kill the cancer cells without damaging normal cells as well. And the SIMCA trial was a phase 3 randomized trial which looked at these men who had symptomatic metastatic castrate-resistant prostate cancer with or without prior docetaxel treatment. And they found that these men actually benefited in terms of survival with the use of radium over placebo. These patients actually had a longer time to a skeletal related event when placed on radium-223 as well. For these patients though, the symptomatic good performance status patients, they should not get Sipuleucel T. Index patient 4 is now symptomatic with poor performance status. and no prior docetaxel therapy. And of course, these patients can get abiraterone, and now enzalutamide is added to the mix of these. These patients who have poor performance status, chemotherapy is not indicated in these patients. However, if they have painful bony metastases without visceral mets, then they would benefit as well from radium-223. In the AUA index 5 patient, these are the symptomatic patients with a good performance status, but they have had prior docetaxel therapy and they have no progressed. These patients, if they have not had abiraterone prior, then they can go ahead and have and be treated with same enzalutamide and radium-223, where the precautions are also options. And cabazitaxel is indicated in these patients. This is a second-generation taxane, which has a broader range of cytotoxicity and higher potency than docetaxel. And it also helps in patients who have docetaxel-resistant cell lines, and it has good penetration to the blood-brain barrier. And its use was determined from the TROPIC study, which is another phase 3 trial, which looks at patients who are randomized to cabazitaxel and mitoxantrone. And they found a significantly better median overall survival in the cabazitaxel group. There was another study as well that looked at cabazitaxel and docetaxel. So even though the mechanism of action for cabazitaxel should be better than docetaxel, there's a study that actually showed that there was no significant or no superiority of cabazitaxel over docetaxel therapy. And from this trial as well, they went on further to do a 2-year analysis. And what they found was that there was an increase in overall survival in these patients at 2 years. And you can actually see on this curve where they actually separate further at 2 years compared to earlier time. And the last AUA index patient is AUA index 6 patient. These patients are symptomatic. They have metastatic castrate-resistant prostate cancer, they have poor performance status, and they've already tried a docetaxel therapy. For these patients, unfortunately, the mainstay of treatment is palliation for them to control their pain and to try and limit disease progression with them as well. And for these patients, abiraterone, enzalutamide are options, as well as ketoconazole with steroid therapy. And these patients should not get immunotherapy or chemotherapy. So with all these agents that I spoke about that are available for metastatic and non-metastatic prostate cancer, castrate-resistant prostate cancer in Jamaica, which agent do we have available? Unfortunately, we don't have much. Apalutamide is supposed to be here, but it has not been approved as yet. Enzalutamide, darolutamide, superlucil T, radium, cabazitaxel, those are not here. So basically, the agents that we have available to treat metastatic castrate-resistant prostate cancer are docetaxel, abiraterone, and ketoconazole. Importantly for these patients, as Dr. Morrison pointed out in her presentation, is bone health for these patients is significantly important, because up to 90% of patients with metastatic prostate cancer will have skeletal involvement. And this involvement may result in skeletal related events, which are severe bony pain, pathological fractures, spinal cord compression, and these patients may require radiation or surgery. Though most of the prostate cancer bone lesions are predominantly osteoblastic lesions, excessive osteoclastic activity is what leads to bone destruction in these prostate cancer patients. So bisphosphonates, phosphonates are important, and these basically block bone destruction. And there are several studies that looked at zoledronic acid use in a dosage of 8 milligrams or 4 milligram. But what they found was that the 8 milligram dosage, the study had to stop that arm because there was increased nephrotoxicity with these patients. But with the 4 milligram arm, there was actually significant improvement in the rate of skeletal related events for those patients compared to placebo. Another agent is denosumab, which is a human monoclonal antibody that's directed against a rank ligand. And the rank ligand is the main driver for osteoclastic formation, for their function and survival in prostate metastases. And basically, this agent inhibits their activity. And there was a large phase 3 trial looking at the effects of denosumab versus zoledronic acid. And what they found was that the median time to the first skeletal related event was significantly better for denosumab compared to zoledronic acid. And this was actually shown that it was superior. Other recommendations of bone health: weight-bearing exercise, muscle building exercise. There was a small study that was published this year out of the UK, which showed that men with metastatic prostate cancer who participated in active sport, playing football was the main thing compared to those who had just minimal exercise at home. The ones who played sport actually did better and had lower skeletal related events than those who did not participate in weight-bearing exercises or muscle building exercises. Also, smoking cessation will actually help to improve bone health, as well as reducing alcohol intake, maintaining an adequate intake of calcium and vitamin D according to the daily requirements. That also helps to promote good bone health in these patients. So in summary, castrate-resistant prostate cancer is still a lethal form of prostate cancer. However, this is being delayed by newer agents. Unfortunately, these agents are not available. Most of these agents are not available in Jamaica at this time, but hopefully soon we should start benefiting from same. The treatment involves a multidisciplinary approach, and these modalities, though not well defined, with use of the index cases, treatment can be better tailored for these patients, and bone health is an important part of the treatment plan. Thank you.
Thank you very much, Dr. Brown. Very informative discussion or presentation again. We've had a very good run of presenters today. Are there any questions from the floor? Any questions to Dr. Brown? Okay, I don't know if Julianne Brown or Mr. Jarrett or someone from the Cancer Society would like to make a few closing remarks, or shall I say goodbye to everyone?
Thank you, Doctor. What I'd simply want to say is I just wanted to thank all the participants for today. I think it was a very useful presentation, series of presentations, well curated, and I think that today we would have answered much of the questions that persons have as medical doctors and laypersons. And I just want to remind you that the Cancer Society needs your continued support. And again, I just want to thank you so much. Thank the team and thank Guardian for their sponsorship. And back to you now, Dr. Roy.
Thank you very much, sir. And I just want to thank the Cancer Society and yourself and Julianne Brown and all the people behind the scenes that have helped to make today possible. I did have a question for Dr. Morrison in terms of the stage shift. I'm not sure if she's still with us, but it would just be interesting to know if there has been a change since the efforts of the Cancer Society and the Jamaica Urology Society, if we've started to see a stage shift in the presenting prostate cancers. I know certainly anecdotally from my experience, compared to 10 years ago, we seem to be diagnosing more people with localized curable disease than metastatic uncurable disease. And hopefully with the continued hard work of both groups and the press, we can continue to educate our population and help to save more lives. Thank you very much, everyone, for tuning in, and look forward to hearing from everyone next year. Be safe and take care.
Thank you, Doctor.
Thanks, everyone.
Roy, I noticed we have lost Tony Hart.
Yes, yes.
He was a good friend too. He spoke a lot about you.
Did he? He was a very, very, very great man. He was one of the few true philanthropists. He was very understated, and he just got on with it. It'd be a big loss.
Thought highly of you. Just thought I'd share.
There are some questions.
What's that, Julian?
We can't. I think we're having technical.
Yeah.
We can't hear you, Julian. That's a pity.
All right.
All right, sir. Well, thank you everyone for joining us, and look forward to seeing you all next year.